we all... Oh, goodness, that's very loud, isn't it? It's 10 o'clock, so we're going to start the informal part of the meeting. I'd like to begin by saying how lovely it is to be back in the Hyde Park room, and what a splendid job facilities have made of the tables and the sound system, which is astoundingly good. So thank you for that. A few wrinkles as a consequence of us not entirely being used to being back here. So the Neds all waited to be picked up, to be taken on the visits, but the instructions actually said we had to go elsewhere, which we didn't get, we hadn't done. So the Chief Executive had to come and rescue us. Because Arlene had organised it in the way it's done at ESTH, they were unexpected visits, whereas at George's we've always done expected visits. So that added an additional frisson into the mix. So by next board meeting, when I hope we will still be here, Stephen,
as in this room, not as in...
As in this room. Well, that as well. In this room, hopefully we will have ironed out all the wrinkles. But I did want to say how delightful it was to be back. And Andrew and I had that conversation. Not Andrew. The governors and I had that conversation earlier on. And it's a great delight to see some of our governors joined us. And our new governor, I think I saw Julian, yes, there he is, a very warm welcome. And of course to very experienced governors too, and to everybody else in the audience. So we will start as we always used to 3 years ago, which you've probably all forgotten, but we do informal feedback about our visits. And so I'm going to start by asking Stephen Collier, who did an extended visit with Parveen, me and Stephen, but he will tell you all about it. Yeah. Stephen, over to you.
Can you hear me or should I put the speaker on?
I think it's better to put it on actually. So at least I can...
We need the microphones for the video, so if you could use the microphones, please.
Okay.
Yes.
It's the green button on the front.
It's a green button right on the top.
Okay, we're live. Thank you very much. Extended in the sense of where we went rather than how long we spent there, which I think will be reflected in the relative brevity of what I report back. It was a very interesting visit to acute medical unit linked to that bit of ED that feeds into AMU, and I think it was a really sensible thing to do, to see the service delivery in AMU and then to go back upstream and understand how some of the patients come to be there. So there were really 3 or 4 broad reflections. AMU itself, a bright, fresh, highly organised unit, clear, very good management of people, patients and visitors at the front door, and a competent staff who were on top of what was walking through that door. The unit is planned admission, 8 patients at any one time, but importantly what it can also do is pick up escalation from ED. And they had a good planning system in place which allowed them to see visually when they were going to have voids and offer that capacity to ED. Staffing was in place, so the roster showed up to 16 RNs and up to 9 HCAs, and they actually had 16 RNs on board, largely employed and bank, but they did occasionally reach into agency. But Helen, the matron, was clearly aware of the cost distinction between the bank and the agency, and appeared to be on top of when she needed to flex staff up to manage demand. The approach on staffing was to fill to roster, which, given the complexity and the throughput, seemed a sensible place to start. But what they did do was share staff because of the alignment of specialty and mission with Caesar Hawkins, and there was quite clearly some very good sharing going on, depending on where the particular pressure points were. So overall came away with a sense of a really good planned unit that can take from ED, and then we went to ED. We didn't go through majors. We essentially waited in the corridor, the ambulance arrival corridor, with Sinead, who's a very capable, I think, senior nurse who's managing today our ambulance liaison. And she gave us a vivid description of the iClip system, managing a flow across a whole series of domains, one of which was ambulance, and Sinead's role was to keep ambulance handover time to a minimum, and she says that over the last week it's varied between 0, which is where it was when we were there, and 5 hours, which would have been some sort of car parking problem across the site as a whole. So overall came away thinking and reflecting, I think, well-managed units, managing some really significant peaks and troughs in activity, and assured about people's focus.
Thank you, Stephen. That was great. Parveen, was there anything you wanted to add to that?
Just to say, thank you very much. Steve's done it incredibly well. But just to say that although they were full, everything was calm. And there weren't people running around and bumping into each other and so on. But I was just very impressed. And I was also impressed with the screen because they knew exactly where every patient was and what they were waiting for. And I loved the little house when they were discharged. There's a little house on the screen that came up saying they'd gone home. I thought that was lovely. So thank you, Gina.
Thank you, Parveen. Parveen and I had a very quick lesson in what I call Cerner, but the staff, of course, call iClip. So, as Stephen said, Sinead was extremely good at explaining it to Parveen, and I were asking probably what appeared to be ridiculous questions. I think the other thing I would comment on was that when we arrived, we arrived in ED as though we were patients, and the first person we met was a person from security who was very charming to us. And we went straight up and spoke to the nurse. And I just wonder at the dynamics of that at times, whether that's the right way to do it. It certainly worked for us, but I don't think we used to have the first person you saw as security. Is that right, Kate?
Are you okay if I just comment on that, Chair? I was invited. Yes, thank you. No, I think that wasn't the case before. I think it's not the right thing. But there's a real resistance and anxiety from ED about moving away from that model, so we're working with them. And I think it's a reflection of the increased levels of aggression that they experience, but of course we all know that that's more likely to be met with aggression than actually if they're met. So I think it's work in progress, but our intention is to move away from the security guard being the first person to welcome the arrival at ED. I don't think it's a helpful approach, but we've got a bit of a way to go to persuade the team down there that that's the right change that needs to happen.
Thank you very much indeed, Kate. I'm glad you're on it, and I completely understand the tensions around that, actually. And he was very charming to us. It's just it struck me as a different kind of message to what I'd experienced before. That's all. I thought it was worth commenting on. Lovely, thank you very much. So the next visit was Jacqueline and Anne, went to Vernon Ward, and Jacqueline's going to feedback.
Thank you very much. So yes, Anne and I went to Vernon Ward, which used to be a urology ward, but has during the pandemic changed to a mixed surgical green ward that has a bit of everything on for patients not meant to be there longer than 2 days. The ward was pretty clean and tidy. We met the wonderful Pearl, who was the ward sister, and she was just amazing. Very staff orientated as well, very much about our staff are brilliant, and the same ethos really as we have about, happy staff tends to be happier patients. We asked her some questions about what went on in the organisation. She feels that she's supported by the surgical division. She feels that she can escalate issues without fear, so all those are important. She didn't know we'd relaunched the values and hadn't seen anything about that. She knew about freedom to speak up and was very clear about how she could use that if she wasn't actually getting appropriate responses from her line managers or the division. It showed us into a very neat and tidy sluice. But of course, first, was the macerator working? No, it's not been working for months, because every time we get it working, it only works for 1 day and then it stops again. It's not an old macerator, but there's something that as part that is required. And so in the meantime, they're putting all the contents of the pans down the toilet thing in the sluice and putting the papier-mâché liners in a bin. So they've got access to something, but you know, she knows about it. She's on top of it. They keep asking. I also get that estates probably really are waiting for a part, because we're waiting for a part for quite a few things at the moment. But it's just I suppose a tick of concern that we've not sorted that out. The patients, it was a lovely visit with a really enthusiastic, loves her team, loves the organisation, loves the work. But, you know, she also was quite good at identifying and trying to resolve things like, it's supposed to be a two-day ward, but sometimes patients come in longer because they're supposed to come in and have someone at home to go home to, and they haven't. And they sometimes need packages of care, but no one's picked that up till they've come in, so they don't go home for a few more days. So just things that I'm not sure, you know, what we can do at pre-op assessment to sort of mitigate some of that. That'd be one of the things. I think the only other thing we asked was, we asked her if there's anything she wanted to ask us, and I think the value of them knowing we're coming is that they think about things that they want to ask, because that's part of it. So there's a bit about we might need to consider about, it's not about them putting the red carpet out, but it actually gives them thinking time about what they need to ask us, because it's as important they feel they can challenge or ask us on that. And there was one more thing, and it just slipped out of my head. Oh yes, there was two questions really. I suppose both for Arlene. One is that they would have an eating chart, so they've got all the bed numbers and then nil by mouth or eat and drink. And it's on the main ward. And whilst it hasn't got the name on or initials, we didn't know whether that was right in terms of patient confidentiality. That's the first bit. And the second question that we had is, do we still need green wards? Because they're still swabbing everybody when they come in. It's still a green ward. I think it's helped protect elective space in doing that, because I bumped into Vicky, the director of the DDNG for surgery, on my way to go and get my stuff after the visit. She said, well, it's helped protect elective stuff. But I'm wondering whether, you know, the payoff between having a green ward and not, and keep swabbing patients and not. It's just a question I've got that we didn't know the answer to, and that was our question. I don't know whether Anne's got anything else she wants to add.
No, and the other point about it being a green ward is that they don't send people down to the discharge lounge, so wondered if that was impacting on flow.
Okay, that's really... Arlene, I don't want to put you on the spot, and you might want to take that away, but is there anything you want to say about the green ward issue?
Yeah, so we really don't have green wards anymore. But there are some areas, because of the types of patients that come through, we have kept, and that is one of those wards. So we don't really have the massive set of green, pink, orange, you know, all the different colour wards that we had before. But in some cases we have, and this one is one of the wards that we have kept, where they do swab the patients that come in, and I think that's the right thing for those patients because of the high risk. But generally speaking, we have done away with those.
Thank you, Arlene. Kate?
I think there's a reluctance to let go of it because it's ring-fence beds. And I think we need to ring-fence the beds without feeling it has to be a green ward, because having surgical ring-fence beds is a real gift. It's really hard to create, and you let it go at your peril. So I hope Arlene and I perhaps can work together with the team to move away from feeling we have to swab everybody and behave differently, but we do ring-fence beds and make sure that other non-surgical cases are not put on that ward, which is the big anxiety coming from the division. That's why they don't want to let go of it, and therefore there's probably a whole set of things happening to avoid it not being green, if you see what I mean. So I think it's a bit of that.
That makes complete sense, thank you. So perhaps we need to say to them, we will ring fence them for you, but you don't need to do all these extra things. Yeah, so can we leave that one with you?
Yes.
Thank you. I'm not sure whether it's UK or Arlene or a combination of the two, but whatever, if that could be action, that would be good. Thank you very much indeed, Jacqueline. So the next one on my list is James, Marsh and Jenny, who I believe went to the Surgical Assessment Lounge. And which one of you is going to feed back?
We'll do a double act,
okay,
but we'll be succinct. I know that will be required. I have to say the element of being caught by surprise by us as two musketeers was writ large. It was quite difficult to get engagement when we walked on there for a while. And that didn't matter, we're not too posh for that, but it also made us think they didn't know whether we were patients or not either, so that wasn't an ideal circumstance. There were things, you know, a variable, for example, should we wear a face mask or shouldn't we wear a face mask? I mean, James is going to come on to other things, but if I could just acknowledge the patient voice in it, because we spoke to a number of patients. What was clear was universal admiration and support for the care received at St George's. Where each one of those individuals had a problem was information, literally, to get there. They didn't know where to go. They described having arrived in the hospital and having to ask 2 or 3 people on the way, where was the lounge, that above, one woman said, but I looked for the corridor and it said paediatric intensive care. I didn't know. And so what is obvious to us is clearly not obvious to all those, and we ought to make that wayfinding clearer. And also a frustration, again, not with care, but with people describing, leaving messages, 3 separate emails, 6 different phone numbers, secretarial inboxes full. So all of them had a narrative about administrative support.
So I don't think I've got much extra to add, Jenny. I think it's fair to say the atmosphere was definitely very calm, and there must be a very high throughput of patients. Personally, I was slightly surprised by the flow of patients, that people come in and are admitted there, but there's also an element of recovery that occurs through that admissions lounge, and how we manage that from a patient experience perspective of people waiting for surgery, potentially being sighted on people coming back after surgery and having the final elements of their recovery was a surprise to me. The lead nurse did, I think we've heard this through other themes on other visits, that we are aware of the challenges of staffing all of our wards every day to safe staffing levels, and not infrequently the lead nurse reported that staff were pulled out of her area to support ward staffing, and that's entirely understandable. But she did reflect on the impact on the morale of her team, that they would turn up to work and not know where they would be completing their duties, and they were in the mindset of supporting the surgical assessment unit. And just reinforce the comments that Jenny was making about the communication that we have with our patients. We ask them to arrive early in the day, but the flow of communication back to the patients about at what precise point are they likely to be going to theatre was a little bit variable. And absolutely what Jenny, the 3 patients I spoke to were incredibly, humbly grateful for the care that they were receiving and felt very well looked after. But I felt that we could potentially think about how we communicate more effectively.
Thank you both to Jenny and James. That's some very clear feedback there, and some of it a bit hard to hear, but nevertheless important, and underlines the value of us doing these visits. I wonder, Kate, I don't want to put you on the spot, but I think some response on that comms thing. I've actually been a patient in the surgical assessment lounge, so I've experienced some of that, oh my goodness, what's going to happen to me kind of thing. And I would endorse, you know, from a personal point of view, some of what you said. Kate?
So, I mean, I think that in some ways it doesn't surprise me, but I can imagine that's really not a great experience for patients. So can I suggest, Chair, I'll take that one away and come back in future about see what the issue is, because it's often about how you change letters on Cerner. So let's get underneath what the issue is and see if we can be more flexible and responsive. But I'll take that one away.
Lovely.
I've got notes of all the things I've been taking, so I'll
thank you very
feed it
much
back.
indeed. Thank you, Kate. Yeah. Right, so that takes us on to Andrew, who went with Tara, who's our new coup, who's just started. Talk about baptism of fire. Andrew, you're going to feed back on Heberden.
I hope that was a comment on from a general basis as opposed to directed specifically at me.
Andrew, do not be so touchy. Of course it was a general comment.
I'll start with the positives, because I think, it's important that we hear those as well. And I think, the visit to Heberden was extremely positive. It's a 24-bed senior health dementia ward. It's been relatively recently refurbished, so the physical environment is actually quite good. There was really positive engagement from the staff as soon as we walked onto the ward. The ward manager was right up with a, "Who are you?" But in a very positive, friendly, welcoming kind of way. Went off and found the ward manager and then took us on an informal tour around the ward to show us everything, and she knew where she was going. She previously had been what's the word? I've forgotten. Like a domestic, but not domestic. HCA? Yeah, not HCA, but housekeeper, that's the fella. She'd been a housekeeper on the ward previously, and so she'd been there. The feedback from the staff, and when we talked with the matron, very positive again. A good team of staff working there. They support each other. There's lots of internal promotions. The matron had been there for 10 years in her role for about 4 weeks. So again, and everything was, in that sense, really positive. And also the ward was really well organised. All the cupboards were locked as you should be. There were no notes about, everything was organised. They have the benefit of some storage space as well, so the corridors weren't cluttered. And you could see, active engagement from the staff with patients across the ward. So, in that sense, really positive in terms of the way that worked. And they've got silver accreditation, and 2 issues. One were around, IPC, and some documentation issues, which they said that they were working on those to resolve and sort out. And again, they were really positive in terms about that. The slight negatives, though, and more about the physical environment. So while it's new, there are some issues. So a couple of relatively trivial ones. There's been some outstanding blind repairs that have been logged, I think, back in February, that still haven't been resolved. And there's also some duct tape holding some of the trunking together in the wards, which obviously is an infection control issue. And they were pointing that out, and they've actually sellotaped their request notices to the Estates Department to the door of the bay as demonstration that they've got it noted. I have fed it on to the Estates Department since we finished. But slightly more seriously than those, there's potentially a design flaw in the bathrooms where the toilets are slightly too far away from the toilet roll holders, and this is actually causing falls issues. And that was raised by several members of staff independently in terms of where that is, and and evidently there were some issues within an SI where it was a contributory factor within that recently as well. So, but I appreciate that that's a design issue that we may need to look at as well. So, but those were the main issues that were raised when we pushed them on anything that they want to feed back to the board.
Thank you, Andrew. We should reflect, shouldn't we, that 5 years ago, when we used to do this feedback, it was all about estates. And we had Sir Norman's famous description of some of our plumbing, didn't we? Which I think for those of us who were present, we'll never quite forget. So it's good to hear that they're very much at the end of your report, Andrew, and that staff are as positive as they are. So that takes us to the last, but by no means least group, which was Paul, Pweeling and Tim, who went to Gordon Smith Ward. So who's feeding back?
Well, if I may, I'll make a start, and perhaps Pweeling, I think, wants to say a few more words about some of the more, I'll call them technical, but medical side of what was going on there. So we were made very welcome in our unexpected visit to Gordon Smith Ward. It's an ambulatory oncology and haematology ward, broadly split into 2 parts. So they have 12 beds, and they were in sort of, there were three shared bays and a couple of private rooms that they had there, and a daycare centre. So I learnt a new word, which was you learnt about aphoresis. I'll let Pweeling say a little bit more about that, but I think what was evident was that they had quite long-term relationships with a lot of their patients. So people who came in for daycare, some of them have been coming in for months, some of them have been coming in for years. They were a very sort of happy team, if you like, in that respect. So Pweeling can say a little bit more about the actual treatments that they provide. We talked about staffing, and clearly staffing was under pressure. In the sort of the daycare unit, their total staff complement should be 9, 7 band 6, 1, 7 and 1, 8, and they're running with 4.4 plus 1. So at the moment they were just stressing that they have a business case in for 3 additional staff, and Michaela, who's the ward manager there, was saying she had everything crossed, but she was being a little bit cynical about whether that was actually going to get through. She appreciated the pressures that were there. It was interesting to talk to Michaela, actually. She has actually been with St George's for 30 years, retired I think about 18 months or so ago, and has come back on bank. She actually was a renal specialist for many, many years here, and came back here to work in this area. And they're trying to recruit a full-time. But it was interesting to talk to her about the experience she has as a bank worker, which suited her very well at the moment, and did press her as to whether she'd like to come back full-time, but that wasn't really something that she wanted to do. I couldn't help myself but ask about IT and estates. Which I thought was quite interesting. Well, they were clearly using iClip. We saw that being used while we were there. And I asked about that. They said actually the only problem they have with iClip is with barcode scanning. And I remember this from some of the other conversations we've had, that actually some of the scanners need replacing. They're just unreliable. And of course that that costs them time, because then they have to enter the barcodes manually. So that was one thing. And on estates, I mean, actually, when walking around it, it was actually quite a nicely presented ward. We looked in their clinical room, which was all really tidy and well sort of organised. And when pressed of examples of the sorts of estates issues they might have, toilets and that sort of thing, they said, no, actually very good. The only thing I would say is that ventilation is a problem in the summer months. It gets really, really hot in there. And that was a problem. They also wanted to show us the gym, which in previous months they have been able to take over as a overspill sort of area, but of course it's been clawed back from them, and they were sort of saying they could really do with additional bed space, because the limit on the amount of throughput that they have is really bed capacity. And if they had a couple more, if they had a wider area, then they could probably ramp up the activity. If you wish.
No, I was very impressed with how organised the ward and peaceful it is. So you walk on it, everyone are going about their business purposefully, and very, very happy to talk. So it was calm. The interesting bit that struck me was there's a couple of issues around the risk that I think we need to think about. One is the staff shortages. They talked about the staff being pulled to cover other areas on the day, and that caused a lot of upset. I think we've mentioned that in Jenny's part. So we need to think about how with staff shortages, whether that's become a serious challenge as we hit the winter months. That's one thing. And the other thing is she described, we spent quite a lot of time talking about the apheresis service, which clearly is Michaela's specialty. She talked about staff burnt out during the pandemic, when they were so stretched that actually 6 out of the staff left, bar 1. They have now rebuilt the team this year, and they are very, very pleased with what they achieve. All of them has gone through the training, bar 1 module, and there's a happy, coherent, skilled team. And she would be very upset to have that displaced, in inverted commas, come the winter months. So she's very hopeful that the business case will go through, but actually they're spending the money anyway. So it's not as if money hasn't been spent. So there's an issue about, well, surely could that be continued? So that was one feedback. And she was also saying that if the staff they're also being asked to cover out of hours. So she and another colleague are being called at 2:30 in the morning to provide cover, but it isn't clear, how is that scheduled? It comes across as it's not scheduled, it depends who's around. We didn't really get to the bottom of how they're then paid. So that's an issue that perhaps we should pick up.
Sorry, for what were they covering?
I think they're covering for apheresis, part of that. It tends to be a call from the ED part. It wasn't entirely clear.
I don't think they have a formal on-call system, and so what they will do is if they're needed, then they'll be rung, and people it's goodwill, and they'll come in and be paid for what they do, I think is what I took from that. They don't have a formal on-call.
Delivering apheresis?
Yeah.
Okay, could we take that offline? Because we're short of time now, and there's obviously some issues there. So thank you very much, Pui Ling, for flagging that up, and Paul for your clarification. Was there anything else you wanted to say, Pui Ling?
No, just a very happy ward. It's lovely.
Great to hear. Paul, any final words?
I thought it was interesting. We've been out 4 times for Michaela's role, and that's why she's still with us, which just shows how difficult some of these roles are to recruit to. And then I think the other thing which was interesting was the fact that they had to move the whole area last winter to create greater capacity, and that was a big issue around staff leaving. And it's such a fine balance. It's a real demonstration of the impact of ED and pressure impacting a ward which doesn't seem obvious, but the impact is definitely there, and it's just a really difficult one.
Thank you, Paul. I think we saw the same in AMU, actually, that these kind of informal escalational areas being opened up because of the pressure on ED, and then them having to be staffed. So I think, our staff are coping with a huge amount, aren't they? And it's an absolute credit to them that they manage as well as they do. So I think quite a lot for different execs to take back there, but generally a really positive set of experiences, despite the unexpected nature of most of them. So thank you very much, colleagues. We're just about a minute over, actually, so I'm going to slide seamlessly, I hope, into the formal part of the meeting. So again, welcome to the formal board meeting. Declarations of interest, as usual, nothing new to note? No? That's good. Can we agree the minutes of the previous meeting? Yeah? Lovely, thank you very much. The action log and matters arising. Let's just get to the action log, because there's quite a lot on this, isn't there? So the first one was about Richard kindly offered to coordinate an all-staff message. Richard?
It's drafted. We're planning to send it out on Monday in Arlene and my name.
Okay, right, thank you. The next one was about further engagement with staff. Oh, the measures that would be helpful. So, Paul, what's happening there?
Yeah, so we've run a series of focus groups and questionnaires. We've had responses from about 450 staff. Essentially what we were saying is, what can we do to help with cost of living type issues? Probably 3 main themes coming through, unsurprisingly, is pay us more, which probably isn't a surprise. The second is transport and things like car parking. The third is, what can we do with regards to food and helping people? So there's a number of things that we're trying to do at the moment. There's a paper which I'm taking to group execs on Tuesday, but it's been a really helpful exercise, so work is going.
Thank you very much indeed, Paul. So presumably that'll go on to People Committee, will it?
Will, yes.
Great, thank you very much indeed. So the next item was about Infection Prevention Control Annual Report, and Richard, you were going to check some statistical benchmarking data.
We're still looking into the details of this. So what I can say is that St George's has not been an overall trust outlier for the most recent year that the Health Security Agency publishes information on. And it's in the public domain that St George's surgical site infections for some orthopaedic operations are not outliers. Indeed, they're very good. But there's some detail there that we're still exploring, because there's a number of things that we have to collect data on. And collating that, I think, if I can suggest this, Chair, I suggest we keep the action open and I give a more thorough update to the board in a month's time.
That would be very helpful. Thank you very much indeed, Richard. So the next item is on maternity, and Arlene, one for you.
Thank you, Chair. So yes, we do have the data on perinatal mortality, ethnicity in particular, and it's reported monthly. So I will send that whole report out to the board members if for information, but we'll include it going forward in the monthly reports that we bring to the Quality Committee.
Thank you very much indeed, Arlene. And the next one, I think, James, is you and Kate. Do you want to start?
I'll make a start. So I think the action related to can we be better cited on on some of the elective challenges that we face in the Trust, how do we benchmark against the rest of England? So what we've tried to put in the IQPR where we have data are some bar charts so that we can visibly compare our performance against other London trusts. I think we can explore with the data team if we can get better visibility about an appropriate peer group for St George's so that we can highlight other large tertiary centres in London. And then in terms of key data about how do we compare nationally, I think it's fair to say that London compares favourably with the rest of the country on the key metrics on the size of the PTL, long waiters, people waiting a long time for cancer treatment, and waiting times for diagnostics. And within London, St George's compares favourably on all of those metrics, but we do recognise that we've got some challenge in terms of diagnostics, and I'm sure we can pick up the detail in the IQPR discussion.
Lovely, thank you very much indeed, James. Just checking, Kate. I didn't want to deny you the opportunity. Thank you very much. So the next item is proposed for closure because Peter will cover it in his audit committee report, I think. Yeah. And then the next two are not yet due. So people happy with that? Yeah, great. Thank you very much. We will minute that accordingly. So that takes us on to item 1.5 and the Chief Executive's report. Jacqueline.
Thank you very much, Chairman, and I'll take it the report as read. Just a few points to pull out. We remain very busy, but I think you know that, wandering around the organisation. And as Kate will go through later on, the plan for winter, which I think we all know will be difficult, not least because we will also be having industrial action layered on top of probably a more than difficult time with our emergency care, whilst we're being asked to continue with our elective care. So keep trying to find the balance with that across both performance, quality and money. I know we'll talk about money all the way through today's board meeting. I think just to also mention that the new cath labs are open, and if you haven't been to see them, we can organise for you to do that because they are absolutely beautiful. They're state-of-the-art and the staff are thrilled working in there. So I think we can organise something maybe at the next board meeting, because it would be good that you actually went and saw them, because they really are lovely, and we've been waiting a long time for them. I think the other thing really to mention is that the operating framework has been published for the NHS, and we've laid out, we've tried to take away and synopsis of what it actually says, and we've just laid that out for the board in regards to that. I don't think I'll say anything more other than the just bringing the board's attention to the new appointments and some of the good work that's been going on in the organisation. I wasn't going to say more than that, Chairman.
Okay, that's great. I barely finished pouring water. So, any questions for Jacqueline? Anne, straight in there.
Thank you. I didn't see it in the Quality Committee report, so I wondered if you could perhaps say a bit more about the Bristol model that we're trialling, because I understand it people are pulled through to wards before there's a bed available. I just wondered about risks. And
so I think I'll just give a little bit of context, then Kate, who's leading on this with Natilla, can talk more about it. So we're one of 6 organisations that have been chosen to trial it in London, and I think we want to embrace it fully. The bit for us is that it federates risk across the organisation rather than just in ED and in waiting ambulances. I think the bigger bit is actually how we then federate that risk across the whole of the patient's pathway. So we cannot have our organisation on Opal 4 and other organisations outside on Opal 2, and so all the risk remains in the acute. So otherwise we'll end up with having 5 extra patients on each of the wards, and still, and so we've just added more risk into the organisation. So there is more to do on that, but Kate's the more of the expert than I am on this, and she's leading that.
Yeah, Jacqueline's put it beautifully, but I think it's I think we want to embrace it as an organisation, because one of our big issues here is we discharge people very late in the day and people don't have a good experience in terms of being delayed discharge to end of day. We will manage the risk very carefully, because it will not be the incoming patient that will be boarded. We'll move the person leaving the ward out quickly. The idea is we try and move those people out more quickly and utilise the discharge lounge, which we're enhancing to support. There is obviously anxiety, because it is a form of boarding, but I think it's about how that's managed on the ward, supporting the teams. We've done a lot of modelling about how we're going to move patients out. We've worked very closely with Bristol to understand what the issues were for them, and also thinking about how we communicate with patients around expectations as well. I do think, though, that we need something here that will ignite a slightly different response in the organisation, because our discharges generally are very, very back-ended and very, very slow, and there are many of those people that can get out sooner if we focus our minds a bit more. But Jacqueline's absolutely right. We're working alongside the system as well about how we can have a similar outflow model working with the systems. We're doing some modelling, working with Mark Krillman in the system, and particularly with Wandsworth and Merton, about how we can do something similar with them to keep that outflow going in a timely way. So it's sort of, we're hoping to start, I was going to pick this up under the IPR, we're hoping to start next week. So we're going to get a sense of, although next week does have 3 train strikes, which isn't particularly helpful. However, we're going to try and navigate that a little bit. But I think what we'll do is bring regular reports back here, and we've got a risk matrix to look at risk and make sure we're managing that and thinking about that in time.
Is that okay, Anne?
Yeah, I mean, I agree that we should look at it, and actually there are potentially opportunities in mental health to look at it. It just does bring a different risk profile, doesn't it? And it just being sure that we're managing that carefully.
And can I just be clear where the reports will come back? Will it come back to FIC? Because FIC would be picking up the review of the emergency
we'll
pathway.
pick it up through IQPR through
Right.
FIC, I think. That seems to be the sensible place to have an addendum to IQPR.
As long as we can be quite specific about it, I think.
Yes.
Thank you.
We
Kate.
need to think about the formatting and
Yeah,
how, but
yeah.
it feels like if Anne's happy with that, that's the right place to take it.
Yeah, okay, lovely, thank you. Peter?
Thank you, Jacqueline, for the report. And you mentioned in passing the resource position, finance and all that. And next week we have the autumn statement, which is going to be, I think, a fairly seminal moment for the NHS in general. I mean, the suggestions are that it may be spared the worst of cuts, but nonetheless that's unlikely to take account of inflation and the growing pressures on the NHS, which we are very kind of conscious of here locally, but happening across the country. So the assumption seems to be that there's scope for significant efficiencies to, as it were, fill the gap. I mean, can you give us a sense of how you and other chief execs within London are feeling about that, and the extent to which there's an understanding of the severity of the pressures currently on the NHS?
Is there an understanding of the pressures on the NHS? I don't think, so if we just look internally, I don't think that all of our 9,000 staff on this site really understand the financial situation we are in, and how we might need to change what we do. We did add more staff into our organisation during COVID. We have not yet taken them out. We're going to have to look at all of those posts and think about what we do and whether we can take them out. And we are not as efficient as we used to be. And if I was the Secretary of State for Health looking at the NHS, that's what I've been looking at, and that is what he is looking at. So I think we have to just be clear that, you know, looking at the NHS at the minute, we've got more staff here than we did pre-pandemic, and we're not as efficient, and no real narrative about why that is. So I think we have to answer our own narrative in that, and we have to collectively make sure that we're as efficient as we can be here, that we do things once, not 35 times, that we equally hold our partners to account for doing some things to stop, to try and stop handoffs for patients, make it easier for staff to do what they need to do, because we can't. There aren't the staff, and neither can we afford the staff in the NHS to continue to keep growing in the way we have. So how do we actually keep it safe while making it more effective? And that is it for me. How do we keep our our patients and our staff safe and becoming more effective? And how do we not keep layering more and more into what we're asking people to do that actually is adding value? So there's a big piece for us around really becoming more efficient, using QI as a way of looking at how we can do things only once, not 3 or 4 times, and how actually we only do the things that add value. And I think that is the big question, not just for us but for every NHS institution. Because at the minute, nobody can answer the question about you're less efficient but you've got more staff. Whether we think that's a fair or not question, that is the question. I don't know if you want to say anything
Well, I think you're so right, Jacqueline. If you're the Secretary of State and you're looking at it from his helicopter, you would say, I think we would all say that actually, that there's a lot more staff than 2019. So what is everybody doing, really? And we have to challenge ourselves. And we are challenging ourselves and have been for some months now around that. But it's hard, isn't it? And it's hard for staff. And we've already heard, that there's an anticipation of additional posts. I listen to that and think, well, how does that square with what we know is the situation? So I think you've described it in exactly the way it's been described to me, that the Secretary of State is looking at it. And I don't think it's an unreasonable question from his point of view. So, any other points for Jacqueline? No? So, despite the fullness of your report, Jacqueline, and that little useful discussion we've had on a couple of aspects, we're only asked to note the report, which we duly do. It always seems such an inadequate thing to do, doesn't it, for such a rich report. So we're going to move on to item 2.1 now, and the Quality Committee in Common report, and this one is for Parveen.
Thank you, Chair. I'll try to be as brief as Jacqueline, but there's a very full report here, and we report 2 meetings that we've had, and as you know, it's a Quality Committee in Common, so we alternate the chair. So just briefly to go through them, and I'll come back and discuss them in a little bit more detail. Things that are challenging, again, life support, and I'll just talk about that in a minute. Mental Capacity Act and the Deprivation of Liberties, again, not as good as we'd like, but there's fairly steady improvement. A lot of problems with C. difficile. Unfortunately, we are already running quite high on that and may well pass the target that we should attain. Birthing problems, mainly in maternity, has been staffing, and birth centre had to be closed. I'll come back to those in a minute, but the bits of improvement, which is always nice to see. Family and friends, very positive responses, 78%, and good to very good. And then going on to the stay, the average hospital bed stay has been 7.5, which again is a little bit higher than we would like, but has been fairly consistent. Complaints, had quite a lot of them, but well resolved, and most of them have been resolved within 96% within 25 working days. So just to 1 or 2 things, the infection, C. difficile, as I said, has been a problem, and I think we'll hear more about it. And of course we went back to wearing masks in clinical areas, which I think Epsom and St Helier were doing anyway, but we've now started out here. Maternity, quite a lot of problems, but I think mainly they are related to staffing and having to close the birthing centre, but we'll be discussing that again. I'm sure I'll be saying much more about that. Cardiac report, where now actually the NHSE as a surveillance group has agreed that the Trust proposal to lift the requirements is fine. Obviously we've now got to do some work to say that we've got a good reputation and people can come back, and I think certainly the the CMO is doing work about that. So deep dives, resuscitation, we asked for this because really it's meant to be mandatory and it's been coming back and back and we never got there. And they've put some, the team have put some very good areas to try and increase the level of take-up. But would you believe it? The major problem was people not turning up. having said they would. So the DNA rate was really quite high, and they've tried several initiatives and trying to get that going. But I just can't see why we can't get it done, and it's I think more the people on the ground rather than the executives doing their best. Pharmacy, nothing. Well, you can read it all there. Risk register, I'll leave it all there. Sorry, just one or two things. Yeah, winter plan, which I think we'll be discussing again later on, but just at the best time, at the worst time, with flu and COVID, we're going to be short of beds by about 55 inpatient beds. That's going to be horrendous, and I think people are working on that. So fairly full report then, very happy to answer questions. We had lots of annual reports back, which I'm sure if you haven't read, they're actually on the website to read. Thank you.
Thank you very much indeed, Parveen. I've seen some hands and I've got a couple of questions if they're not going to be asked by my colleagues. So Anne first and then Tim.
So this may not be for you directly, Parveen, but I was thinking about the complaints where all three contractors left. It sounds unexpectedly, people dealing with the complaints. And I suppose I was just concerned, given that this is a really important source of feedback, isn't it, to us, about how we kind of manage the fragility of that service if we've suddenly got all the people leaving.
Is it Arlene, this one for?
Yes.
Arlene, are you able to comment on that? Oh, it was about complaints and contractors leaving.
No, I will have to take that away because I didn't know about that.
Okay, all right. Can you get back to us on that, Arlene? Thank you. And
the performance, I mean, the complaints are probably about the same level, but the performance of sorting them out.
yes, yeah, but nevertheless, Anne's point is...
Yeah, absolutely.
Yeah, thank you, Parveen. Tim?
Thank you, Chair. I guess we always at this time of year hear a lot in the press about the twindemic of COVID and flu and what might happen. And of course, we're going to have a paper later about the winter plan, which is good to see. But I just wondered where we were internally on the take-up amongst staff of COVID and flu vaccinations this year. It's something we've paid a lot of attention to in previous years, and I'm just keen to ensure that it doesn't slip off the radar.
I can take that one. So we are leading the program on flu vaccination and COVID vaccination across nursing. And the latest figures I saw that we were, for George's, were around 36% of staff vaccinated for flu, correct. And COVID numbers as well are around there, but increasing. So we are doing quite a bit with comms around encouraging staff to have vaccinations. And there's some posters that are due to go up soon of Jacqueline championing it all. Jacqueline has done a really emotional video that we have published as well. So we're doing lots of work in the background, and we are keeping on top of it as we have done in previous years. It's not gone off the boil.
Oh, Peter?
Just on that point, do we have a breakdown of patient-facing staff who've been vaccinated? Because that's the key area of concern, and if they haven't been vaccinated, are there any consequences arising from that? Thank you.
Yes, we do have a breakdown. We have a paper actually going to People Committee next week, Friday, which will have the breakdown by patient and non-patient facing, ethnicity, and all of the other aspects that we need to look at. So we do have that.
And that's flu and COVID?
Yes, flu and COVID.
Thank you very much indeed, Arlene. So I thought perhaps, Arlene, you should comment on the maternity staffing because it's something that we hear periodically. We know the birthing suites had to be closed. We know that we've put a huge amount of effort and additional resources into the recruitment activity. So I think it would be helpful for the board just to hear from you on that, if that's okay.
Yes, so we have put a lot of effort into ensuring that our maternity staffing improves. We did have quite a number of vacancies, but we've got a whole new group of midwives that qualified in the summer, and they have started. So they're in there, quite new, but will get up to speed quite quickly. We continue to work with Jan and her team continue to work with their colleagues across the trust, actually, and in some cases we have managed to be able to get some registered nurses into to do some of the tasks that they can do in maternity. So that work continues, but we do know that there are vacancies, and we are starting to work now together. I met with the two directors of midwifery across the Georges and Epsom and St Helier, start talking about how we can even share staff across as well, if we when it's possible to do so.
Thank you very much indeed, Arlene. Any other questions or comments from colleagues? Paul, were you indicating no? No, that's quite. I'm just checking. So we're asked to note the report. We've also got to look at the Learning from Deaths report, which has been to Quality Committee. But Richard, do you just want to make up some brief introductory remarks, and we'll check whether there are any questions from colleagues who aren't on Quality Committee?
Sure. I think the things I draw out from this, probably first of all, we're expanding the medical examiner service, so that's actually happening now. So the aim nationally is to make sure that community deaths are scrutinised by the ME service as well as hospital deaths. I think it's very commendable that the ME service has scrutinised all the non-coronial deaths in this quarter, April to June, all 358 of them. So I think that's an important quality assurance piece, which is very robust. I think it's worth pointing out that we always highlight in these reports any individual area in which we're doing particular work to scrutinise mortality. And as before, we're looking at acute myocardial infarction. We have been looking at intracranial injury and also looking at trauma in general. And in fact, the mortality signal for intracranial injury that indicated that we should have a more careful look at it has gone away. These signals do come and go. We have to recognise that because a lot of things are tracked. But work is ongoing to work, particularly with trauma. And of course, that brings us back to the work we're doing to open a trauma ward. Sorry, did you want me to pause?
Sorry, I thought Anne couldn't hear you, but I was wrong. She can.
Okay, good. And I think the other things, the two other things that I draw out, our SHMI, our Standardised Hospital Mortality Index for the last year, is as expected, statistically rather than lower than expected. It's something we keep a very close eye on, but the hospital standardised mortality ratio remains lower than expected, which is a good thing. But it is something that we keep a very close eye on, and we keep a close eye on the details, which I hope this report gives assurance about. And then just in the most general sense, our mortality teams at St George's and Epsom and Helier are actually working quite closely together, learning from each other, sharing good practice, thinking about the way that we support the clinician leaders who do safety and governance within their own areas. So that will continue to be a work in progress, but there is quite a lot of close working between the two teams, which I think is a good thing.
Thank you, Richard. That's really helpful. I thought it was an excellent report, if I might say so. Very thorough. Pui Ling.
Thank you, Chair. I thought there was an excellent report too. Always delightful to hear that actually the service is expanding quite so rapidly and to time. Very interested to hear about the pilot that started in July. I'm just wondering whether when do you think we might have sight of the outcomes of that pilot with the aim that it will be rolled out across the two boroughs?
We would give an update in the next quarter, Learning from Deaths report, which of course will be due at Quality Committee, I think, fairly shortly. So it'll be in the next report.
Thank you, Richard. Any other points? So the recommendation is quite long, so long that I'm not actually going to read it out because it would take quite a long time, and you're all more than able to look at it. But I would ask you if you're prepared to support that recommendation. Yep. Thank you. And remind you that we did note the Quality Committee in Common Report. So that takes us on to item 2.2 and maternity services. And Arlene, this is one for you.
Thank you, Chair. I will take the report as read. I think just in terms of highlighting the clinical negligence scheme has been running for the last 4 years, so we're on year 4. And part of the requirement of that scheme is that we do bring this report to board, which highlights under specific safety actions where we need to be as an organisation. I think for St George's, the highlights or the issues that we have in terms of compliance are around what is known as Safety Action 2, and that's submission of data. We haven't been able to do that because our system doesn't upload to the national system. We have asked for some exemption for that, so I'm not worried about that. The one that maybe is a slightly bit of a concern for George's is around the inability to ensure that we have a supervisory or supernumerary shift coordinator, and we've talked about the staffing, and that means that we don't always have somebody on the shift who is just there available to support, when sometimes they have to be drawn into the numbers, which means that we keep patients safe, or women and their babies safe. So there's not an issue from that perspective. It's just that as a requirement for the CNSD, we're not going to be able to achieve that because we can't do it 100% of the time because of the staffing challenges that we have. And apart from that, the other areas, St George's are either compliant or on track. We have had a directive about being able to pause the continuity of carer model for George's. We have chosen not to take any new women onto it, but we're ensuring that we, particularly our ethnic minority women, are still in that, because there is evidence to show that for those women it is much more beneficial to be looked after in that way, or to be supported during their pregnancy in that way. And I'm not going to go any further into any of it, but I'm happy to take questions.
Thank you very much indeed, Arlene. Jenny, and then Parveen, and then last word to Jacqueline.
Thanks very much. Just because this is a public board, this is a summary of a conversation that we had. And I just want to say we as Quality Committee did penetrate, because there's been some very high-profile maternity failings, and we were able to reassure ourselves, and we had that discussion. Was it possible that a similar thing was happening here? So we penetrated the data and got that feedback, and thank you to Arlene and others who expressed a view that our services were safe under those challenges.
Thank you very much, Chair. It's really about IT, because we're in the red for this latest review, mainly because we haven't got IT that will actually fit onto the main board. I mean, it just seems to me ridiculous. And we've got the money, I think 1.8 million or something, to improve IT. And I know that they've now bought the package. But just generally, I mean, the whole hospital depends on IT. What are the problems? I mean, ever since I came, IT's always been a problem. And that's, it's about time we got to the top of it. And I just wonder whether somebody could tell us when the IT system will be functioning, and how soon the maternity can get on there.
Thank you, Parveen. I will sweep these points up. Jacqueline.
Yes, I'll let Andrew do a bit of IT. But if you think it's bad now, Parveen, you should have been here 5 years ago. It was super bad, and it's a huge improvement. But we still have some tweaking and some additions to do. I think my question really is about we get a premium for CNST compliance, and just what is the financial penalty for not complying with CNST? So we've assured ourselves in terms of safety, but financially there is also a penalty, and I don't know what that is if this looks like it does when it goes, or if it has gone, what that actually means.
So thank you, Jacqueline. That would have been one of my questions, because I'm conscious that there's quite a lot of money caught up in that. So Andrew can probably take that, and the IT. But Stephen, you wanted to come in on another important point, I think, which is in part related to what Jenny was talking about.
Yeah, it sort of followed on from Jenny's comment about the recent maternity failures elsewhere, and the Kirkup review of the failings at East Kent were published back a couple of weeks ago, and just kind of what our process is for reviewing the report and the findings of that, and identifying the learning that we need to potentially apply here and across the group.
So, Arlene, I'll take Andrew first and then come back to you, if that's okay, is it? And certainly we do need a discussion at board about Kirkup, the Kirkup report, for sure. Andrew.
IT. Yeah, as Jacqueline sort of paraphrased it, where we are might not appear good, but where we are is a lot better than where we were. And actually recovering the IT situation from that point was always going to be, to put it crudely, a 5 to 10 year task. We need to rewire the whole hospital for Wi-Fi. That's why one of the major concerns is the Wi-Fi is poor. But that's because putting Wi-Fi in a very large concrete and steel building is a very complex task. It's not like at home where you just take it out of the box and plug it in and it works. We will have to put hundreds of miles of new cabling into the building, and it will be an extremely disruptive exercise as we do it. But that is exactly what we are doing. So there's been a huge amount of work to put what I'll call the back office bits of IT, if I use those terms, the bits that you and me don't see and don't really understand. But it's taken 2 to 3 years to sort those out. And there's been a huge investment in that. Now we're beginning to move into the rewiring of the hospital, which will then allow the systems to work more effectively and more appropriately. That's a very crude overview of terms of some of those things in the sense of for brevity here, but we can talk more in detail about that. But there has been a complete review of the IT risks which have gone through the Finance Committee, and there's a clear action plan for moving us to address all of those risks in terms of moving the IT environment forward to a much more stable position. Individual systems are on that list, and maternity is one of them. I don't know the specific timelines and dates for that now, but I can find that out. But I know, those things are always being balanced within the wider programme of things. So, iClip is always a challenge for us. We have just been onboarding the new laboratory information management system, which has taken quite a lot of effort to get that landed, and that's a system that runs, across the whole of southwest London. So again, there's lots of competing ends for those things, so it's a constant balance. But these things are definitely in a work plan, and as I say, that work plan is visible through to the Finance Committee in terms of where that goes and the order of priority and how we're addressing them. So, but maybe if we speak outside in terms of the specifics.
You want to come back specifically?
Yes, just that this is just so important, because I think on this we may well lose a lot of money, and it's all to do with IT. Can we not put some more money in to actually improve it and make it quicker?
I don't think it's about money.
It's not about money?
I don't think it's about money. I think it's about staffing and the work that needs to be done. And certainly I have raised the point in FIC about whether it's being given the appropriate priority. And I was absolutely assured by Elizabeth. She clearly understood the importance of it. But as Andrew says, these things are all important, and there's a limited number of IT skilled people available to help do the work. But Andrew, I do think the board needs to understand the potential loss of the CSNT money. Is that more for Arlene than you?
I have a number in my head. I'm hoping it's the same one.
Let's test it.
Telepathy isn't going to work.
No, I was going to say. No, the incentive that is at risk, I think, is about £1 million.
Yes, it is. So it is about £1 million. So because we have always achieved it, we don't know what it would mean for not achieving it. But what I do know is that for trusts that don't achieve it, they don't get the full £1 million, but they will get some funding to support in areas that they have not been able to achieve. So we will get something.
So I think the board, I'm trying to draw together some implicit comments. I think the board would want us to do as much as we possibly could, given other priorities, to maximise our CSNT funding. CST. Whatever, yes, those letters, in the right order as opposed to the wrong order that I've just got them in. And Arlene, could you speak then about the Kirkup, is that the report, and when we're going to get, I'd like a report to the next board?
Yes, so in Kirkup report, and if anybody hasn't read it, it is quite harrowing actually. And so we have all individually, as in the chief nurses and the directors of midwifery, been reading it. The plan is that we will sit together and do a gap analysis for where we think that we are, that we can bring to the board, because it is, I mean it's a requirement of Kirkup, but I think it is for us good practice anyway, if something as significant as that comes out. So that is the plan, that we do a gap analysis around where we think we are. Some of it is very it's the softer skills around people just playing ball, being part of the team and all of that, which we're not going to be able to measure, but I think it'll be really important for us that particularly for those who work in the service to be able to have a view as to where they think they are on those, because as I say, some of it was, I don't think you can measure. There is no measurement about how people play ball or not, or how transparent people are around issues, how midwives speak and consultants, doctors, whoever speak to patients and reassure them. I do have to say that I saw a CQC concern this week that was raised around midwifery, and from the responses that the team provided, I feel assured that the team are aware and willing to learn. So a lot in the Kirkup report is about the softer stuff around culture. So we're going to sit and do that and bring that to the board.
Thank you very much indeed, Arlene. Jacqueline.
So that was going to be our point. A lot of that was about culture, and what I don't want us to fall into the trap of is thinking that if we put loads more staff in there, it'll all be all right. Because we know that doing that often just magnifies the problem even more rather than actually making sure. So I'm sure that we can, with some of our OD team, find some metrics or some ways of measuring team working, relationships, incidents, openness and transparency, and a culture of learning. And I think that for me is the bottom line. Money isn't the issue, I don't think, here. And I suppose I just don't want us to fall back on that, thinking that that's going to address it, when actually it's about how do we really bring teams together. And I think midwives and obstetricians, particularly the relationship between them, that is the bit that we need to focus on, because I think that's the area where sometimes there's either gaps or there isn't relationships, there isn't team working. So I think for me, those are the bits I'd want to understand. So whilst it's soft and not easily measurable, there are things we can look at that tells us actually, I think, where we might be. So I just wanted to say that, Chair.
That's really helpful. Thank you, Jacqueline. I think it's been a very helpful discussion. Sorry, you want to come back on?
Yeah, and just to support that, actually, what Jacqueline has said, there's very little mention in that report about staffing levels. People say sometimes it's busy, sometimes we're short, but the majority of stuff is around how people work and how people talk to each other, and that the culture thing it was massive, and that resistance from the board, from board level down to anybody having a look in, anybody, so CQC raised concerns. They'd had several reports over several years about things going wrong in maternity, but the board always said, but we're good, we've got good outcomes, and that is some of the stuff. So some of it is maternity, but some of it is our responsibility as well. So.
Yeah, I think that's a really good point. And as a board, we need to challenge ourselves that we're not being either fobbed off or we're just taking comfort where we shouldn't take comfort. We have to ask hard questions of ourselves, and I hope we do. But it's a challenge we have to keep setting ourselves, I think. So I think we've covered quite a lot in that discussion. Obviously, the whole CSNT. Getting as much as we... Sorry, I keep getting it wrong. You're all laughing at me anyway. You know what I mean. That scheme, and making sure that we get as close as we possibly can to meeting the criteria and maximising the funding available. We've had the discussion about IT and the challenges there, and the importance of prioritising maternity. We haven't spent any time asking questions on continuity of carer, but Arlene did cover that, and it is an important area. And I think implicit in the fact that no one's questioned it is we're supporting what is articulated there, Arlene. And then finally, I think that helpful discussion about East Kent and the fact that we will get a report, that we will be challenging ourselves as well as our service around cultural questions in particular. So with that kind of richness, we're asked to note the report. Is that all right? People happy to do that? Yeah? Great. Thank you very much indeed. So that takes us on to item 2.3 and the Integrated Quality and Performance Report.
Is there a maternal perinatal thing we needed to do that was added onto this?
We've just done it.
Oh, was that it?
Yes,
right, okay.
yes, we've just done it.
Sorry.
Go back to where I was. James, are you starting?
Very, very briefly.
And then over to Kate.
But just to comment that this has been reviewed in detail at the Finance and Performance Committee and the quality elements of the Quality Committee. But I'll hand over to Kate to talk through the detail, and I'm happy to support any questions.
I'll be brief because I'll take us through some high and low lights, I think, that I know questions will come up about, but very happy to take questions. We've talked about emergency flow and ED in terms of what we're doing around what we will call regularised outflow in terms of the Bristol model. I think probably it's worth noting that St George's performs really well on 4 hour, even though we're obviously off the sort of 95%. We're often the best or second best in London. However, we're poor performing around 12 hour, and therefore it's really important we look at the flow of patients and timeliness, and that's very much going to be our area of focus. We did see a reduction in ambulance handover times and 12-hour trolley waits in September. And it's hard to actually pinpoint what that was about, but I remember the time well, and it certainly did coincide with us managing to bring our ready for discharge patients right down to about 50. So there's something about how we work at both ends of our system to make that a sort of safe and sustainable position. If I move on to elective, which I know is really quite challenging for us, we under-delivered in September against our elective and day case capacity delivery compared with 1920. We're about 7% under plan, 6% if you add in the bank holiday issue, which we haven't accounted for. We have a number of specialties that are underperforming, and we are working with the services and teams around a recovery plan. It's been a little bit slow at getting what we need. I think some of that has not been helped by, we've had quite a lot of turnover in the division, and we've lacked a divisional director of operations in that division as well. We have now got quite a lot of new staff in, and I'm working with Anna to help, and obviously I've got my new coup in now to actually look at how we really get a grip of that over the next few months and have individual service plans around recovery, particularly around things like T&O, who have all their theatres back because we've moved out the CPOD theatres from T&O, so there's a lot of, and they're procedures that obviously have higher value as well. So we will bring back some trajectories on that into a future meeting. The theatre productivity is improving. It's slow, but you can see from the pack that we are seeing an improvement in theatre productivity. Queen Mary's is still our weak underbelly around theatre productivity, and there's a piece of work we're going to do both around Queen Mary's and looking at our CPOD capacity about whether we need to turn some of that back over, or considering our financial pressures, what we need to do about that. So again, that's a piece of work we're doing with the division and with the organisation. Outpatients, we're tracking around the 1920 delivery, but and I know Stephen raised this because it's a concern that we've raised before. We have a very high non-admitted PTL. We're not eating into that enough. And I think there's a tripartite approach to this. It's the validation that we need to do. We've got doctor, we need to properly roll that out. There's recovery work we need to do, and there's transformation work we need to do. We intermix that a bit here because what we're doing in transformation really should sit in recovery. PIFU is something when we're just sort of patient-initiated follow-up we're not doing enough of here. There's been lots of reasons why that's been difficult. We've now got a plan to really accelerate PIFU because PIFU will help us utilise capacity more effectively. Advice and refer, we are having to come off the kinesis system, or we're needing to focus on that first, and then that's another area we need to focus on. But we are looking at putting some more capacity than we've currently got around transformation and recovery. it's just an area that has been neglected, I think, for want of a better word, for quite some time, and we need to get a different response working with the teams. We've got some new leadership down there and enthusiasm. I've had support from James around transformation support to provide more focus on this, but I think it's an area of work we really need to focus on. It's going to again be an area that I want my new coup to really sort of drive in terms of outpatient transformation. So very aware that that's something we need to get a grip of. We are doing more first now than follow. We're seeing the sort of dynamic changing, which is good, but we've got a lot of work to do in that space as well. The other, a couple of more areas I just wanted to touch on. Cancer, another area of challenge for us. We had I think I reported in the last board that we were seeing a real growth in the backlog, particularly in dermatology, due to an enormous number of referrals over the summer, way beyond anything we've experienced before. And then we have breast, which continues to be a very challenged service. We have a really credible recovery plan for dermatology. The 2-week wait position will improve significantly for them over the next 2 months. 2-week wait for breast is really poor. It's pulling down the overall performance around 2-week wait, and this has impacted on our faster diagnosis standard as well. So we have now a regular piece of work and oversight of work going on in breast, and I'm going to suggest we bring something, because we brought something before specifically about breast. I think we need to come back to FIC with where we're at on some of those things. This is the job planning bit. I think they've had a particular challenge over the summer in terms of people not being willing to work waiting list initiatives, but we're too dependent on those, and also sickness in the team. So we're going to, we'll pull it all together in a paper about the recovery planning and where we think we're going to bring that to by when. But that's an area of real pressure. As I say, dermatology has a good improvement plan, which I'm confident that we will deliver on. And but we've also managed to bring the backlog right back down again to below trajectory. So that is playing out in the 62-day performance, because we will be clearing backlog and treating more breach patients. So cancer is another area that we need to focus on, which we are focused on, but breast in particular. Diagnostic performance is deteriorated in the month of August to September. It's now 11.6%. However, that's largely driven by two things. One is gynae ultrasound, and there's a really good recovery plan. I can see looking ahead, we've already improved on that, and we expect that to be fully recovered in the month of November. The other driver for that is endoscopy, which we also have a number of challenges in, and we've got a recovery plan for endoscopy as well. And I'm just working with the team about looking at when that's going to be in a stronger position. We're going to be running Saturday lists in endoscopy. Again, I can bring more detail on endoscopy services and why we got into the situation we've got into and how we're going to get out of it. That drives cancer less. It's more of a DMO1 issue, because we obviously prioritise cancer over DMO1 diagnostic. But there is there's a plan we'll bring back around endoscopy recovery, but that diagnostic performance will improve over the next few months, because we can see that's improving. There's a couple of just quality ones I was going to raise around. I think there's some flags around C. diff infections and pressure ulcers. Pressure ulcers has been high for a year now, but there's a lot of focus from the senior nursing team on this, and we've begun to see a bit of improvement. So it's being picked up in the work that the matrons and the heads of nursing do every Friday, and I think we can already begin to see a bit of an improvement. So that's a high level of focus from the chief nurse, Natilla. And then C. diff infections, looks like we will miss the target of 43 cases of the financial year, but there's been lots of work done around antimicrobial stewardship, which is an area that that's an area that we need to focus on. And a review of cases has not actually revealed any particular cases around stewardship, but again, we need to get underneath and understand this and how we can improve it. I think they were the main areas, Chair, that I was going to raise, but obviously I'm happy to take any questions about anything that I haven't talked about or anything I have talked about.
I'm sure there will be some questions, because I've already seen two hands. Yes. So three. Stephen, Anne, and then Peter. Oh, and Pui Ling. So we'll maybe take a couple of questions and then have some answers, and then another couple of questions. Stephen.
Yeah, so very helpful report, and you're very upfront about the problems, and the problems are here and now. and it can't even be questioned, it's just an observation, the absolute urgency of turning around the indicators that are going the wrong way is critical. We will simply not make our budgeted year-end position activity-wise unless we see the improvement come through now.
Yeah.
I should say I took huge assurance from the last F&I where we did give you, well not you, but we gave others a bit of a hard time about some of those indicators, and it's clear the executive is on it, but it's just there is no dwell time for reflecting on what's going to work. We've just got to throw everything at it. I accept that's where we are, but if we can just keep the pressure on.
Yep.
Thank you.
Absolutely.
Thanks, Stephen. Anne?
So I think that covers kind of one of the points, because we did express concern at the Finance Committee around the underlying increase in the PTL. And, but what I wanted to come back to was cancer, because we've had concerns expressed before about cancer performance, indeed amongst the Council of Governors. And I just wanted to check whether or not, because you did bring a return to green plan through the Finance Committee, whether we're on track with that return to green plan, some of which we know won't actually come green until the next financial year. And also whether there are opportunities across the system, you know, so like dermatology. I had some personal experience of dermatology, Kingston. It was very quick, and I just wondered if others have got some spare capacity, whether or not this is an opportunity for us.
Do you want me to, sorry, I realised I left my microphone on, apologies. In terms of the return to green plan, which would bring us back to compliance in Q1 of next financial year, we want to remain focused. I'm most concerned about breast. I think it's incredibly, there are lots of wicked issues in that service. There are issues around engagement, resistance to change, behaviours, which have been long-standing and we have not managed to resolve. And breast is a high-volume specialty that you really do need to be performing well. So for me, breast is the biggest risk. I do think dermatology, and I take your point in terms of looking at mutual aid and whether I think our service here is excellent, but it was deluged with referrals, and do we need to think about how we spread that across the system and what the appetite for that is. And there are some other bits within, you know, max factor is a bit of an issue, and we know GI is an issue, but all of those have recovery plans in place. So I think my biggest concern around the green plan is breast and getting that back on track. But having said that, we are focused on continuing to deliver that, and to be honest, because that's what we have, you know, that's what we've committed to. So we want to keep focused on getting ourselves back to where we were and then continue to plan to deliver in Q1. But it isn't without risk.
Thank you, Kate. James, did you want to come in specifically on this?
If I can just pick up the second comment from Anne about dermatology specifically.
Thank you.
So it is a huge pressure across South West London generally, and across there's been an incredible surge of referrals since June. I think it's beginning to tail off now that people are putting on longer sleeves again and not noticing funny lumps on their skin. The teams across all of the trusts in South West London have all been under strain. They've all been focusing on the referrals that are coming in as potential suspected cancer, although the pickup rate is quite low. But that has come at the price of referrals that are not suspected cancer, with increasing waiting times for first appointments. We're trying to embed teledermatology as a way of rapidly triaging, hopefully offering suitable advice without patients needing to come into hospitals, and triaging appropriately so that the right patients are seen as urgent patients. We have struggled at St George's to get teledermatology off the starting line, in part because of some IT challenges, surprise, surprise, and some other operations, including St George's.
That's really helpful. Thank you very much indeed, James. So I've got Peter and Pui-Ling.
Thank you. And 2 points, the first of which was on cancer standards and breast, and just to underline the concern, I think, of all of us at both quality and finance around this. And I mean, the fact that it's going to be a further sustained effort to get back on track to deliver the plan, I just wonder, there comes a point, obviously, when we may need to amend the plan, and it's just whether there are contingencies maybe you're holding back or maybe need to be rethought rather than just kind of pushing harder and harder on the existing plan. Because anyway, I mean, it's just to flag that point. And the second was a more general point that I think we found it helpful and we're assured there would be a growing focus on the group-wide IQPR. And this is point to James. There was a little bit of confusion this time about where our focus should be on, but I think that should be resolved for the next one. But I think the value of that, and I think you can see it through the emerging report, is now much clearer and beginning to show areas of common interest, is that ability to share good practice across the group and to really start to realise some of the benefits. We hear sometimes about some of the challenges, but there are potentially big benefits, and the group IQPR is going to be one of the vehicles through which we can really pursue that. Thank you.
Thank you, Chair. I've got 3 points that I just want to raise. The first one, of course, is I would completely underline Stephen's comments on the data that's presented shows in August that actually we potentially will be heading for a downturn of many of our performance indicators. And of course, in the situation in the board, we get an update from you of all the activity that's going on to make sure it doesn't continue to go down. And I'm just wondering whether can we be reassured that when we come onto the winter plan that we are going to be in a position to really try and secure the trajectory into a positive turn, because we're always quite understandably looking at data that usually 2 weeks behind, so we have to rely on you to update us of what is the current situation when we see each other. So it's about the security of knowing that actually we are heading in the right direction when we don't have underpinning data to convince us that we are. So that's the first point. The 2 points that I want to just raise is about the flow of patients into our hospital. So how secure do we feel that actually we have robust work going with our partners outside of the hospital to work with the flow of patients into our services, so, and also exit out of the hospital. So therefore our conversations with our providers like the primary care lot, like our ICS colleagues, of people flowing in and out of our hospital. And very interestingly, the third point is reading our DNA rate, which is in Diligent 144. The highest DNA rate is amongst our older group of patients from 45 onwards and up to 85, and also highest in our BAME community patients. These are resource that actually is wasted, and I just wonder to what extent I'm sure we are, but it would be useful just to understand the flow in and flow out, and also the use of our resources that we give to our patients who clearly are just wasted opportunities.
Thank you, Pui-Ling. Jenny, did you want to? Okay, fine. So, Kate, you've got a few points there. Have you got them all?
I think so. I'm not sure I'll do my best with yours, Pui-Ling, but in terms of looking at the plan, I think we constantly need to look at the plan, and we know we're off track at the moment, so I think we will continue to review whether we can get on track in enough time. And I still have not got all the work through from Breast about recovery and where they think they can get to by when, so there are some missing elements, but your point's really well made, and absolutely it's still quite dynamic. Pui-Ling, your points about pathways in, so we do have really strong place-based meetings where we sit with primary care, community services, so I regularly sit at a macro level, we discuss this quite a lot. At a micro level, we work with GPs around, so for instance, ED pathways, how you can bypass ED and go straight into SDEC on various. I'm not sure if that's what you mean though, in terms of pathways in and pathways out. Do we work with our system partners? Absolutely. Could we do better? Absolutely. Do we need to be admitting less people than we're admitting? Absolutely. And it touches on the winter plan. And we do need to, the discharge could be a lot better. So I think all of those areas are work in progress, but we do have fora where we do talk about these things, and really quite good relationships, particularly with Wandsworth, but also with Merton, who we work most closely with. Don't know if that answers that question.
So I think there was a point about DNAs as well.
I was going to come on to DNAs, yes, but in terms of the pathway question.
Yes, so it's really just getting a sense that is that sufficient as we're going to go into the winter months, and of course then we will also discuss that at the winter planning.
I think there's always more we can do, but actually it's quite a complex set of. So I think we need to operate effectively with our system partners at the place-based meetings and make sure we're moving. So we have started with Merton and Wandsworth regular winter planning touch points where we can try and unlock things together, because there are lots of things that don't perhaps work as well as they could do, and where we need to communicate better. But I think we need to constantly talk together and work things through and try new things, because it is really a tough environment we're all operating in. In terms of DNAs, they are too high. They've come down a bit. One of the things that we are implementing is, I'm trying to remember what it's called now, Consultant Connect, or something, where we're going to be ringing patients on list to check. They're still expecting they know they're on the list. They do still need to be on the list, and just checking in around engagement with coming to the organisation. So that will help do two things. One, help with validation. It's doctor, I think it's called. Help with validation, but also will help drive down DNAs. I think there's always more we need to be doing with DNAs, and it's quite variable by specialty, and they're, again, multifactorial around the way patients are booked and etc., and the length of time people wait. But it is an area of focus for us, because it is absolutely wasted precious resource, although we often overbook to accommodate that. However, that's not necessarily the answer, but I absolutely appreciate that we need to do better on DNAs. I
think the other question, the other question was about the overall direction of travel. Really, is it going in the wrong direction?
Well, it's quite a hard thing to answer. So going back to Stephen's challenge, we need to have. We have not yet. I do not yet have assurance in terms of electives that those services are going to be delivering at a high level. I haven't got it. And I think what we've got to do is land that and understand so we can't be spending more money. So WLIs are out. So it's about understanding what we can do. And I know we can do more than we're currently doing. So at the very least, we need to be delivering on plan, if not over-delivering. So we are all over that and working on, with Anna's support, meeting with all the teams and working that through. So that's in terms of elective look forward. In terms of cancer, we always report a month in arrears, but I can see now what our backlog is doing, and I know it's going in the right direction. I think it's then also having service demand and capacity plans, which we've now got up and running in breast, for instance, things that have just not been in place, and looking at tracking what we're going to do. So it's again building the trajectories in the plan and checking how, in a lot of service we just haven't had those things, and it may be as a result of COVID, people changing over, but we need to put in some proper systems and processes for looking forward. So I can see some of what the future brings, and in other areas I haven't got enough assurance myself. So I've now got a coup who can help me with that. But we're sort of really focused on getting, that's how I want to work. I don't like working blind any more than anyone in here does. So I think there's quite a lot of work we need to do around infrastructure and getting systems and processes up and running again in the way we need to.
Thank you, Kate. That's very helpful and very honest, so thank you. Jacqueline, you wanted to come in?
I did. I mean, there is we've realised we've turned through most of our GMs in the last 2 years. And that hasn't helped because we've got no local history as much, and some long-term GMs have gone for understandable reasons. Either they need to change, they've gone to, but that doesn't help. So we know we've got some capacity issues and some performance issues, but that's for us to sort with our management teams. I think Kate's outlined and briefed some of that. But I just wanted to say several things. Number one, it's right that we and the board pushes us about how much more we can do and need to do, and how we are managing what's going on in our organisation on behalf of patients and of staff. So I think that scrutiny is really welcome, and we need to keep having that because that's the right thing to do. We have to keep balancing that against the other bits of the stool, so we can't just do everything just in the sake of performance, the same as ditto with quality, so we have to keep balancing performance, quality and money all of the time, and that is part of our role. But I think I just want to give a little bit of comfort to the board, and you can take it and then leave it and carry on holding us to account. But we do have a weekly scorecard across London about where each trust is across 104-week waits, percentages of over 18-week waits, cancer and diagnostic. And St George's tends to be about 4th or 5th out of the 20-odd organisations, because it includes all the tertiary services as well. So actually, across all of that, when you look at it, we're doing pretty well. But that doesn't mean to say that we need to sit here and say, actually, that's all right, then we won't do anything more, because we need to do more, because either others will catch us up, and actually we want to do this for patients, don't we? So I just wanted to give the board a little bit of comfort about where we are, but we can't rest on our laurels, and you still need to push us.
Thank you, Jacqueline. I think the context's helpful. I was actually going to give a bit of APC context, which was to say that we had a very good APC board meeting yesterday, and there was there's a lot of supportive challenge, I think, and confidence on the part of our partners that we are tackling these issues. So we heard from the two other chief execs that when they're working with your people, Kate, in some of the detail about outpatients and diagnostics and things, they can really see detailed working plans, and they believe that the commitment to deliver. So I was quite encouraged by that. But they're also equally clear with us that we're the problem child from the point of view of activity, but they both also own the areas where they've got problems. So I think it was a helpful discussion, and a bit like Jacqueline, it reinforced that we're doing a lot of good things, but we've got a lot of other things to do. So I think the board will continue to challenge on these things, because it's our job to do that. But we have to do it in a realistic way that recognises just how hard people are working, and that we're part of an encouraging challenge, not negative challenge. And I hope, Kate, it's not come across as negative. Good. I think that's really important. So a good discussion. Thank you, colleagues, for your contributions. I think for me it's been about activity, cancer, particularly breast, and I don't want us to lose sight of C. diff. It's not a good place for us to be. I'm not suggesting anyone is, but we've inevitably focused a lot on activity, and we need to keep that infection prevention control in mind as well. And Paul, I think we can probably deal with the people issues under the People Committee, but just in case there was anything you wanted to flag up on the IQPR?
Just probably three things, if I may. The first one is, we don't normally talk about MAST, but actually I think it's worth just very quickly just reflecting on MAST, because it's actually pretty good. The performance is good. It's 13 out of 16 of the MAST areas we're performing at green, which is positive. No core topics are in red, which again is positive, and the thing that I'm pleased with is it's been like that for over 3 years, so that's I think it's worth just noting that. We often talk about things which aren't working so well, and so it's good to have an opportunity to talk about things which are working well. We've just in terms of turnover, we've just completed, Arlene and myself have just completed a nurse retention toolkit, which is being produced by NHS England, and we'll bring the results of that through to the People Committee, but it's worth just noting we've completed that. And the final thing is around the agency spend, and it's positive to see that this month we've hit our target, and quite a bit of that has been around interims and reduction in spend on interims, which we targeted at the start of the year. So it's good to see that coming through.
Thank you, Paul. That's good to hear all of that. Any questions from colleagues? that's a relief because we're running a bit behind. You know, I don't like that. I could begin to get anxious. So I will be beginning to chivvy people if we continue to lose any time. And I'd like us to gain some. I'm going to move on now to 2.4, the winter plan, and just remind everybody that it has actually been to both Quality Committee and FIC. But nevertheless, Kate, you might just want to say a couple of things.
I was hoping we'd make up time on this item, Chair.
Great stuff. We're
For
in
the
the same
reason
place.
exactly as you said, it has been through FIC and Quality Committee. There was just a couple of things I wanted to add. One to say that we've spent time on really focusing on this and scaling it down and looking at the areas we need to be spending our time on. However, there's just a supplementary. I've just wanted to bring the board's attention to, and because we have obviously the bed modelling, which is not new to George's. This isn't a new bed modelling issue. This has been something we've been holding for a while. But something that I guess that slightly exacerbates this for a short period of time is our major trauma ward being closed for refurbishment. And I think it's important I let the board know that that was due to be handed over this week. But unfortunately, the work has been quite significantly delayed because of ability to get access to products and services, products particularly. I won't go into the detail, but we can bring something back if that's helpful. We have decided to move forward on a sort of interim plan of bringing some beds back up in December, and then we will then need to close the ward again, probably in the spring, and then make it formally into the all singing, all dancing trauma ward. So incredibly disappointing and frustrating, but we'll find our way through to make sure that the winter is not impacted by that. And I suppose the other thing I was going to mention, which we have touched on earlier, is industrial action, is something we're doing a piece of work outside of the winter plan, but we'll need to draw some of that in. This is still, I'd say, a work in progress winter plan because we are not quite into the formal winter period yet, but I think we'll need to play in what we're going to do around industrial action into our winter planning, because I think that's going to literally be a winter of discontent. And we've got 3 train strikes next week, so there's a lot of challenge over and above the challenges that we already have. And the third thing is just the way we work with our system is absolutely key and critical. We've picked that up already, both in what Pooling's raised, Jacqueline's referred to. So continuing good working relations with our system partners but appropriate challenge and support where needed, I think is going to be absolutely key, because a lot of the capacity that we're putting in place this winter is dependent on partners delivering. So that's all I was going to say in addition.
Thank you very much indeed, Kate. I did think a very good plan, actually, really clearly written. Any questions for those who didn't have the opportunity at Quality or FIC, or have thought of anything subsequently? No, that's good. Good to hear. So there's a very long recommendation, which I don't propose to read out, but I would direct the board to that. It's a series of notes, but can we support that, please? Yeah, lovely. Thank you very much indeed. So let's move on then to item 3.1. We're 15 minutes late, so if we could all just keep that in our mind. And Stephen, you're going to introduce the report from the People Committee.
Yes, I'll give a brief update. I'll take the report as read. And I'll just pull out 3 elements, one of them very, very brief. Culture, operations and efficiency. It's just worth mentioning that our culture programme continues. It feels very much more embedded in the organisation, and there's some early indications of joint working with Epsom and St Helier. There's very good focus on values and living our values, and strong focus on development of our middle management, which is obviously a good thing, particularly in the light of the recommendations, the verbatim recommendations from the Pulse staff survey, which said improved management as the primary area for trust focus, and anybody who'd like to can look at page 190 on Diligent for that. But within culture, I thought also just to mention a couple of things that were real concerns to us 12 or 15 months ago, and that related to medical education. We had an unexpected, unanticipated GMC survey result, which slightly caught us off guard as we came out of COVID. Well, the GMC's been back, and the good news is what they describe in our postgraduate medical education is much improved. And I just think it's important we reflect on that. As a board, we often go for the things that aren't working well, and actually this has been done well. And it's reflected also in the feedback we've had from our undergraduate trainees about their environment being much improved. So I just think it's important that when we look at culture, we look in the round. So that's culture. On operations, really two things to highlight. Firstly, we've made incredibly good and fast progress on catching up on the DBS backlog. And the committee recommendation is that we re-rate this from 16 down to 8, and I hope that the board could accept that. And I think the other thing to call out on operations is the very positive and engaged active management of bank and agency spend across the trust. The two metrics are going in the right direction. We're using relatively more bank and relatively less agency, which is exactly what we want to see, particularly at this time of year. And then the third area to call out is efficiency. Efficiency, as we know, is hard to deliver. As Jacqueline said, with all the parameters around quality and service delivery, efficiency is an area of tension. Just a couple of points that I think are worth making. Firstly, there is a workforce improvement plan that we have underway that the committee is continuing to review. Efficiencies that fall out of that are going to be up to 6 million, and we'll continue to monitor where that's likely to land. We may or may not make the full total, but we'll keep that under close review. And the other area that we haven't got into in any detail, but we've started to review, is the increase in the establishment. We've got 500 more full-time equivalents than we had in April 2021. Of the 500, about 250 are tupied in functions for either procurement or pathology. But that does leave 250 new posts. And we had a look at that in November, and we think it's time that we had another look at where those posts are gone. And 250 against 9,600, 10,000 doesn't sound huge, but it's 2.5%, and it's a significant amount of spend. And I think one of the things the committee will want to do is just to understand where that resource has gone and what sort of delivery we're getting as a consequence of it. And I reference that specifically in the report. It's something that Paul and the team are cited on as something we will come back to, but efficiency is becoming an increasing point for us. I won't say anything about RES or WDES because they're both in the pack, or on the nursing establishment because, again, that's in the pack. But I'm very happy to take questions, or leave it to you, Chair, to take us through the meeting.
Thank you very much indeed, Stephen. So I've seen Stephen and Jacqueline either side of me. Can't see. Oh, and Peter. So, Stephen, did you want to go first?
I can do. It was just a really small point about the DBS risk, and the committee discussed, as Stephen said, sort of reducing that risk score from a 16 to an 8. I think that's not something we need to agree formally as a board. Probably the one thing I'd flag is that maps across to SR9, the sort of workforce risk on the BAF doesn't, it plays into that, but it doesn't fundamentally shift that risk, which remains on the BAF as a 16.
Can I just observe, one of the things we did have was an early look at, if current improvement continues, where we're likely to be at year end on SR8 and SR9, and we're feeling quite assured about the mitigants in place around that. It's dimensionally different from where it was 18 months ago.
Thank you, Stephen. That's really helpful. Thank you, other Stephen. Thank you, both Stephens. Jacqueline.
So I just want to make the point that looking at that staff bit is responsible for all of us, and particularly with Kate, because what we can't have is Paul being responsible. I know that wasn't what you said, but Paul might know the detail. It's not for him to action, and I just want to make sure we have collective executive responsibility over that. Sorry, I just wanted to make that.
No, I think it's a really good point, because there's a tendency to say it's all for Paul and Andrew, because it's about people and money, and actually it's about the executive team.
And as a committee, we absolutely recognise it's the executive, not one person.
Yeah. Nevertheless, it's always worth making these points. Peter.
Thank you. 2 points. The first on Paul earlier mentioned about the turnover figures being, I think, pretty good from what you were saying, or not where you were, but actually just more to flag that there's a risk that things could get worse through the autumn and into through the winter, given the indications are that pay awards will be no more than 2% next year, and given current cost of living pressures, I suspect that might be the final straw for many. Therefore, just to log it, there's going to be a lot of extra work arising from that, I suspect. But the second is around who we target for recruitment or re-recruitment, because the indications are a lot of the drop-off in the workforce during COVID and beyond is from the over 50s, those who've retired early. But perhaps when they realise that pension isn't being stretched as far as it will, or the cost of living is proving difficult, they are increasingly looking to come back into the workforce. But what they'll be looking for is flexibility. And if we can design packages in the right way, it seems to be quite a fertile area to be looking at. I'm sure you are, but just to be interesting to hear what your thoughts on that.
Paul?
Couldn't agree more. I think you're absolutely right. And this morning was really interesting. We went for our visit when we were talking to the manager there who's come back. And this is a really hard to recruit role. Like I say, we've been out 4 times. And her view was, I want to be able to take some time off occasionally. She's an older person. And actually, if we look at it, and it's not something we do massively well. We have got to get better. It's complicated, particularly when you've got real, strict rotas. But we're in a position where we have no choice but to work something out, because I think you're absolutely right. Money-wise, we're not going to compete, and actually it's about how do we create greater flexibility. Well, you're 100% right.
Thank you, Paul. Necessity is the mother of invention.
Yeah.
Jacqueline?
So I think that's absolutely right. And I heard someone from Milton Keynes speak the other day, and they basically say to people, how many hours do you want to work? And they're getting more to that because we have a different, both ends of the spectrum, people coming into the service and people at the end of the service. And sometimes the people in the middle of it want to have a different work-life balance. So rather than saying, well, we can't have you if you only want to work 3 hours a week, actually that might be better than nothing. And actually we need to be far more flexible, and we just need to put a little bit, help our, particularly our middle grade leaders, whether they be on wards or whether they be in general management, to think a bit differently about it, because at the minute it's an all or nothing, and actually we can't continue to work like that. We have to be far more flexible, otherwise we will lose huge amounts of people because of that. And so I think that is how the question for me is, how do we get that engendered throughout our organisations about flexibility is good, and can we live with it and work with it rather than think that it's absolutely a no-no. So I think, I'd want to see how it goes in Milton Keynes and actually adopt some of that, because I think we've got a different, people think differently about it now, and we need to start doing that too.
Absolutely. Stephen?
So agree, and from a different part of my life, I know that we can't all work flexibly. There'll be nobody here on a Saturday night. And that's one of the challenges that we're going to face, is finding the right balance. We will get there. And Paul's currently, don't anticipate it, Paul's currently doing a deep dive on nurse turnover and where they go. But one of the points that Paul's pulling out of that is those who migrate from full employment to bank. And then if that is a significant proportion, what's that working pattern? My experience elsewhere has been, if you get them doing a bit, generally, if they get comfortable with that flexibility, they'll do a bit more and a bit more. So I think there's the opening to something within that. But flexibility is almost more valuable to some staff than the money. Actually, it's not a substitute, but it's a contributor.
That is absolutely the case. So we're all in danger of violently agreeing with each other, which means it's time to move on. Are there any other particular points before?
Arlene wanted to say something.
I'm sorry, Arlene, I didn't see you. My apologies.
No, it's okay. I think we must stress as well that for nurses, the middle managers are the blockers, because nurses like structure, and we're always used to 7.5 or 12 hours, and if you can't do that, then you're out, and that is still a key issue for us. So I do think that that is where we need to put a lot of focus.
We do, and Arlene, I so often hear the fairness thing. It's not fair. I'm the one who always has to do, the really unsocial hours. So I think we understand the issues, and you have our absolute support in moving that forward, but we're having to take a lot of people with us who haven't had to think that way before. Right, so we'll note that report, but we also need to look at the WDES and the WRES, which both of which were properly looked at, I think, in the People Committee, but nevertheless there are people here that are not don't attend People Committee. So all board members had the opportunity, did they not, Paul, to comment on the report? Over to you.
Thank you, Chair. So the paper is brought for noting. Just at a very high level, what you've got this year are quite different performances in terms of our RES and our WDES. So with the RES paper findings, which are around race, you've seen a pretty good improvement. We're still not at parity and where we want to be, but it's positive to see that pretty much in all of the indicators, we've moved in the right direction. Probably the only indicator where we're still quite a lot to do is around senior level representation. Most of the others, we're moving in the right direction. So you'll see that represented in the key themes within the RES action plan, which are about improving the equal representation leadership, de-biasing recruitment, improving career opportunities and creating an anti-discrimination culture. That all leads into that area. That's not to say we're being complacent about the other areas. It's just good to note some improvement. I can't say the same thing for the WDES, which looks at disability. We've seen that's been a much more mixed picture. What I would say with the WDES, and I think we just need to be cautious, the number of staff who self-declare as having a disability is very low. So we're looking at 2%. And what often happens with these areas is the absolute numbers can distort the percentage figures. So there are examples where actually when you look at the results, they look 4 times worse. When you look at the absolute number, you're talking 1 or 2 members of staff. And so that becomes a problem. And so for me, the thing that I'm most focused on for the next year is how do we improve that representation and self-declaration, because we have this conversation every single year, which is, that we can't really take much from the numbers because the numbers are so small, and therefore the only thing I can think to do is to do a big piece of work, which is around encouraging people to self-declare. That said, you'll see that the themes there are also around equal representation, around people with disabilities. Again, building an anti-discrimination culture and improving managerial and organisational support for staff with a disability, which is really important around things like reasonable adjustments. As I say, the paper has been to People Committee, it has been approved, but very happy to take any questions.
Thank you very much indeed, Paul. So, Arlene?
Paul, I just wonder, the Declaration of Disability, have we done enough around encouraging people to not encouraging people to declare, but educating people on what can be considered as disabilities? Because I think people, everybody knows if you have one leg or you have, that's a disability, but there are other, not all disabilities are seen, and I know we have signs around that, but have we done enough? And maybe that's something that we should do.
I think there's 2 things for me. One, you're absolutely right, the education piece. So if you look at the definition of a disability, it's about an impact over 12 months. And so people don't really always see themselves as having a disability. But the other thing, which I think is a more practical issue, is we tend to ask this question when people join an organisation. And actually what often happens is they develop disability whilst they're with us. And so there's actually no point there are opportunities for people to self-declare. They don't know how to do it. And so there's a piece of just really practical check-in. And that's what I think we need to do next year, is literally write to everybody and get an update on a variety of different issues around different diversity characteristics, of which one disability is one of those. So for me, it's an education piece, but it's also a practicality issue.
As Arlene knows, at ESTH, we tried really hard on it, didn't we, Arlene? I wrote to all staff, and we really we still haven't made as much progress as I would like. We have to change we have to change the conversation, but then some of us around this table were involved in the Calibre programme, which is an absolutely great development piece that we did between ESTH and George's, and I think it was Imperial actually. And Kate and Paul and I certainly heard the projects fed back to us of a number of our staff who've got disability, and it was a demoralising experience because their experience of working in the organisation is not where we need it to be. So we've got a long way to go, for sure. And getting people to have the confidence to say they have a disability is really important, which is why, you know, I've never made a big thing of it, but now I never miss an opportunity to tell people that I've got hearing impairment. Because I want to encourage people to feel safe in just saying something that is about them. So anyway, I'll get off that particular soapbox, but it is something I feel really, really strongly about, and Paul's made those points so clearly. I can't see any other hands. Oh, so I'm so sorry, Kate.
Just very quickly, I think the three things. One, you're right, giving people the confidence to declare. Secondly, there are some people that genuinely don't want to be thought of as having a disability and therefore don't want to be noted that. But thirdly, I think you're absolutely right, Gillian, it's about how do we look after and treat people when they need adjustments to their working environment. And I think we're particularly bad about that in the NHS, despite the industry that, you know, we're a people industry looking after unwell people. So we're not accommodating enough, which I think that programme really highlighted. So therefore, it's not very incentivising to declare a disability if you can see that people are not getting a good experience. But
I personally think we need to challenge ourselves quite hard on some of that reasonable adjustment stuff. I read a report in the last few days that said, unless you move the budget centrally, you never shift the goalposts. I don't know whether that's true, but I merely make the point that it was quite a compelling article.
Sorry, Julie, I think that's true, because the amount of times I've had to intervene with people with a disability saying, my manager says she hasn't got the money, she can't do it. It is heartbreaking. So usually it's go back, just do it. But there is something about it being easy to do, and we put too many blocks in to do that.
We do indeed. Anyway, I think what we should acknowledge as a board is that the paperwork is in a much better place than it's been in previous years, and a big thank you, Paul, to you and your team for that. I still think there's a bit too much in some instances, and I'd like to see more commonality between the two trusts, but I hope the board will support me in acknowledging that this is really a step change in terms of the paperwork before us, and we have seen real progress in some areas. We'd like to see real progress across the board, but I think a good piece of work, Paul, and so thank you to you and the teams. Any final points? We're just asked to note this, so I think there's lots of nods around the table, so that's great. Thank you. And then 312 is the nursing validation report. Arlene.
Thank you, Chair. And this report is just a short report to give assurance to the board that there is a process for ensuring that our non-medical professionals who are registrants do renew their registration or update, or they continue to be registered to practice in the organisation. I think so we've done this across the group, and some of the learning that has come out of it is that we need to strengthen the process for George's around our allied healthcare professionals. So those are the ones registered with the HCPC, and so there's a small action plan there about how we're going to do that and align the policies that we have across the both organizations. In terms of any outstanding, there weren't any for George's lapses in registration, and so nothing to do there, but we have set up regular relationship meetings with the NMC and the HCPC for George's, which we already have in place at Epsom St Helier.
Thank you, Arlene. I did think it was a really good report. Thank you very much to you and whoever was involved in its preparation. Any questions or comments from those who didn't see this at Quality Committee? No? Oh, that's happened so fast I haven't got the recommendation in front of me.
It's terrible, Chairman.
I know. Must do better. There we go. We're asked to receive the revalidation paper for assurance and make any necessary recommendations, but I think we're supporting the the paper. So thank you very much indeed, Arlene. And if by magic we're actually 2 minutes ahead, so all is well and I am relaxed again. And in fact we're going to gain a bit of time because the next paper was not complete, and I agreed with Paul that we needed a complete paper, so that will come to next board, and I will be working with Paul outside the meeting to make sure that everything is as it needs to be. So just wanted to report that to colleagues and move on to item 4 on the agenda, and item 4.1, the Audit Committee report. Peter.
Thank you, Chair. The Audit Committee met this time last Thursday, a good, very straightforward meeting. I'll just touch on a few of the items that are flagged in the report. Firstly, we had a general update and progress on the internal audit plan, which is progressing well. In those, for the most part, recommendations being implemented where not updates were given. Just one or two areas, which I won't mention, were identified as where there's a bit still awaiting responses. Similarly, a bit of delay in reports, in responding to reports, and updating on progress. So I don't want to make too much of that, given how busy everybody is. But the point is really that when, whether it's the internal audit team or others chasing, it's wasted time. And everybody's busy, so actually sometimes it can be quicker just to hopefully give the right update, give the response and move on. But nonetheless, overall, internal audit plan generally progressing well, which is a good sign. We received 4 reports, just one of which was limited assurance, and that was in the area of procurement. And this was surprising, and Andrew may wish to comment on that, but nonetheless, there was some lack of evidence, shall we say, in relation to a number of tenders or quotations that, which has been, shall we say, looked at, I think, closely, quickly, and if there are issues underlying that, including training, we were assured that they would be addressed quickly, and as I say, Andrew may wish to comment on that. Otherwise, 2 or 3 points. We had a helpful report from Steve on previous internal audit reports have flagged that governance issues kept on cropping up on a fairly regular basis. And when we looked at this in more detail, it was around the updating of policies was the primary cause of those issues. So it just underlined really the importance and benefit of timely refreshing of policies, so that will ensure it's the right thing to do, and it will also avoid a lot of the further recommendations coming forward. So again, noting everybody's very busy, but that was an important kind of conclusion that was reached. We also had a brief update on declarations of interest. Again, I think George is in a relatively good place, helped by a new system which is less clunky and easier for people to use, and elsewhere in the group I think they've got to catch up on that, and hopefully we'll make similar progress. The final point, Chair, is just around, as you mentioned earlier, around the what was then in private discussion, but I think we can now basically just confirm that the procurement, or the tender for internal audit will be progressed now on the basis of a South West London consortium, if you like, principally with Kingston and Croydon. And initially we were just going to develop this on a group-wide basis, but following further discussion there was enthusiasm, shall we say, to progress it on that wider basis, which I think is great in terms of underlying kind of collaboration. It should be an excellent example, should also make the contract more attractive to potential bidders. A bigger contract, there's more benefit, and hopefully that will trigger more interest. So the audit committee here and at Epsom St Helier approved that as in principle last Thursday and Friday, and on Monday of this week I met with the chairs of those other the other trusts and signed off the tender process to go, which I think Steve should now have actually gone live. So we'll reach a conclusion in mid-February for the start of the next financial year in April. So it's tight, especially as there's a handover to be made to a new provider, but nonetheless we're assured that there will be a strong focus on that from all involved to make sure that works well. So, Chair, that was all for now, I think.
Thank you, Peter. That's really comprehensive. So I think it would be helpful, Andrew, if we could hear from you on the procurement point and the tender documentation, and then perhaps from Stephen on the policy stuff and anything you want to add on the consortium, and then I'll take any questions. Okay, is that all right?
Yeah, no, not at all. I think the simplest way I can express this, I think it was a failure to engage with the audit as opposed to a failure within the systems and processes within procurement. But I am picking that up with the department.
Thank you, Andrew. That's all we need to know. Stephen.
Yes, so the review that we undertook of internal audit recommendations relating to governance sort of followed from the head of internal audit opinion that the board discussed back in June. And that was really highlighting that sort of benchmarked across other organisations in the NHS. We had an unusually high number of governance-related recommendations coming out of internal audit compared to some other comparable organisations. So we wanted to dig in and understand why that was the case. And it was the case that the majority of those actions did relate to a combination of things to do with policies. Often policies not being updated on schedule on the time they were due to expire and be reviewed, or developments externally running ahead of where the policy was and the policy not being proactively updated even if it technically remained in date. And then there were some aspects around compliance with policies that were in place but people weren't following them. So those were the bulk of them, and I think the report sets out here that of 33 governance related ones, 20 of them related to policies of various sorts. That's, you know, some of them were multiple policy related recommendations to do with individual areas, but it was a theme that spanned a number of internal audits, so I think it's worth drawing that out. There were also some issues to do with training as well, which also came through. But I think that piece, and so one of the things we're doing is reviewing, and this partly responds to a separate internal audit, reviewing how we do policy governance across the trust, but also more importantly across the group, both to make sure that we harmonise policies, but also we have a systematic and consistent central process of chasing people for updates on policies to make sure that that's all in place.
Thank you, Stephen. That's really helpful. So, questions or comments about the Audit Committee report from Peter? No? Oh, did you need to say anything about did you need to add anything to the point about the South West London thing?
No, I don't think so. I think Peter,
okay, that's
Peter covered
great.
it.
Tim, you looked as though you were about to say something.
Thank you, Chair. Yeah, just very briefly, I mean, I do recall the conversation about policies and really the opportunity that is presented across the group, if you like, to harmonise those policies. Not an easy job because the policies don't actually match one for one when you look at the lists of them, but nevertheless it seemed a very worthwhile exercise, not only in terms of getting the policies up to date, but also as an instrument for helping common sharing of good practice and commonality across the trusts, really, which seems a very laudable thing for us to do.
Doing things once rather than twice seems like a good idea, doesn't it? Okay, so we're happy to note that report. Thank you, colleagues. That takes us on then to item 4.2 and the Finance Committee in common. Anne.
Thank you. We usually catch up time, don't we, on the finance report? Could be famous last words. So we've got the newly named Finance Committee, which actually does have a very broad agenda, because obviously we cover all aspects of finance, but we also do cover IT, estates and performance. So it is a very big agenda and takes quite a lot of concentration to get through all of the agenda items. Nevertheless, we do persevere. I won't go through all the aspects in my report. What we do by rotation is we look at the risks, the strategic risks that have been assigned to the committee around operational IT risk, financial sustainability, investment and the estates risks. And we're going to talk about the BAF later, but we have kicked the tyres on those risks. And whilst individual elements, particularly around things like IT, go down, it is like painting the fourth bridge, and as fast as you close one issue, another one pops up. But I think, and I think Tim would agree, that we have, just thinking about the conversation we had earlier, we have addressed some of the fundamental risks around IT over the last few years, but it is a big task. The estates, I think we've made huge progress. Jacqueline, in her report, referred to the cath labs that are open, the MRI unit. It was really nice. We took a report that brought together all the big capital projects that we are running across the trust. And there's some really big projects on there. So it was actually really nice to recognise that we have not only, those of us who've been on the committee for some time, have seen these things from inception to now actually being live and delivering good services to patients. So that was really, really helpful. And we also, I think I might have referred last time to the fire that we'd had near to our ED department. And we did a review on the learning from that, actually caused by the hot weather. So some learning for us on that. I won't repeat all of the conversation that we had around performance because we've already given a thorough review on that. I suppose the two things I just would re-emphasise, but I think we've already mentioned them, is I do think we need to come back to our cancer path to green at our next meeting. And the other point that I think Stephen made quite helpfully at the committee and again today is around the underlying increases in our PTL and what that says for the future. You know, we're sort of managing today or there or thereabouts, but it's actually there's a wave coming down the tracks. On the money, and I probably steal Andrew's thunder because otherwise there's nothing to say on the money. So we are still planning for this year. We're managing this year. We're forecasting the outturn, and we've started to plan for next year, which is an unusual place to be when you're in November. But it is the way of the world. I think in terms of where we are, we're where we expected to be year to date. We've reported some deficits as we've been asked to do by the system, but actually on year to date we are where we expected to be, and that's not the best of places, but it's a good result that we actually are where we expected to be because it shows that we know what's going on and have some grip on that. We're taking a particular interest at the moment on cash, and that's not to say that we don't expect to run out of cash, but when you're expected to make quite a lot of savings, managing those savings in a way that's recurrent is key to your cash position, and if you have to use non-recurrent methods, then it does impact on your cash ability. But the committee was assured that we are all right for the current financial year. The position on what the outturn will like for this year is very challenging. I think we've talked about that. Jacqueline talked earlier about balancing quality, performance and money. It is really difficult. We are continuing to look at how we breach the gap, but it is looking quite challenging, and I think the committee were noting that. Equally, the gap as you start planning for next year looks quite daunting as well. I mean, it always does look big at this stage of the process. But I think what that says is that there is an underlying deficit at George's that those of us who've been around for a few years have known for some time, and it hasn't gone away. So I think that means we will always struggle. So I think they're the key points from the committee. Those that managed to stay to the end, it was 4 hours long. So, I don't know if there was any other comments from other members of the committee, Tim or Stephen or Peter.
Well, let's check that out. But thank you very much for a very clear account of the committee discussion. As you say, it was long, but I think we all managed to stay the course, which was a testament to your chairing skills, actually.
Quality was long,
Right, okay, stop. We're not pursuing that particular conversation any further. So any questions or comments for Anne? Tim?
Thank you, Chair. Just very briefly, I just really want to support some of the comments that Anne was making around the BAF risk scores. I think that the BAF risk score isn't actually a very good indicator of progress, in that we've made quite a lot of progress in a number of areas, but that doesn't necessarily move the dial on the risk. The examples I would give is data centre resilience. In terms of fire, flood and power continuity, we've done a lot. Cyber, we've done a lot, but I was arguing quite strongly actually that I don't know that actually the progress we've made on cyber necessarily moves the dial, because I think that the cyber risk is an ever-moving threat, and it's something that we've absolutely got to keep a focus on, and keep our eye on that ball particularly.
I think between FIC and Audit Committee we do.
Oh yes,
There was a question mark at the end of that, but I think we probably do. Thank you, Tim. Any other points people wanted to make? No, so we're asked to note that report.
So I was just going to. I guess
sorry,
the point.
you had a question as well.
Forgive me. No, I'm sorry. Just on.
Sorry, now let it.
Yes, on that moving of the scoring, I think that it can sometimes be. What's the word? Disincentivizing, if you like, some of the staff who are very involved in the work that goes on behind the scenes to not see those scores come down. They really want to see that happen, but I think that us keeping a focus on it and keeping those scores where they are in some of the instances is the right answer.
And I hope we do in FIC, though, Anna, give encouragement, particularly to the IT and estates folk who probably experience that more than others. Unless you're finance, of course, where despite all the efforts, the risk goes in the wrong direction. So, but I hope we get the tone right, Anne. I think you do. But anyway, points well made. Thank you, Tim. Right, so if we could note that report, and then that takes us on to item 4.3, which is the finance report at month 6. Andrew.
I'll try and keep this reasonably brief, but probably give a warning that next month and in subsequent months we probably will need more time to talk, because the position will become more interesting. As Anne said, we are largely on plan at the moment, which is good news, but we need to remember that plan is for a 29 million deficit at this point, or sorry, slightly less than that, 23 million deficit, in the sense of where that sits. So that's a good news, bad news story, as I would call it. Good news, as Anne says, we are where we said we'd be, but that is a 23/29 million deficit. We also know the challenge that we face will continue into the second half of the year. If anything, our financial plan, which was for a break-even position, indicates would require us to have significant improvement on the run rate that we've had to hit that position as we enter the back 6 months. I think the conversations that we've had at the committee, we've discussed here, and certainly we will discuss more in part 2, in the challenges of finding the actions to get to that. I think we can say here it is not complete, and therefore we are looking, at a deficit for the year. That's why I think we will need more time to discuss that as we move in. I think this links to some of the issues that we've seen elsewhere. Stephen's comments about there being, additional hold times in the position, some of the challenges around performance and pressures on activity in terms of what that means and how that sits. But also, the investments that we have made, and I think that's been mentioned a couple of times. And these are things we will need to look at in terms of what we've done across COVID. And, that focus is there in terms of how we can bring that forward. And I think that's important, again, to Anne's point, that as we look into 23-24, those pressures continue. There are, we will see a further withdrawal of the COVID funding that we received, across the COVID period, which will exacerbate the challenges. And as Peter's question earlier around the wider sort of national economic position and the pressures that may come from that could further sort of challenge us as well. So there are stormy waters ahead in the back end of this year. But as you said, we are where we said we'd be at this point. So I will go to questions.
Thank you, Andrew. Any questions for Andrew? I think we all understand these numbers quite clearly, don't we? So I can't see anyone, Andrew, so I think we're required to note the update, but also note the comments you make about what's coming down the track. So that takes us on to item 4.4, which are the corporate objectives, and this is over to you, James.
Thank you, Chair. So this is an update following the board development seminar that we had a few weeks ago. We are aware that we are actively developing a new strategy, which we anticipate will be signed off by the end of this financial year, and that will drive our new corporate objectives and implementation plan. However, we are aware that we haven't signed off our corporate objectives for the past year, and it would be right and appropriate to agree objectives for the second half of this year. Whilst our existing corporate objectives largely align with our current view of the world and priorities, we do need to recognise that we are in a different landscape from where we were when we agreed them over a year ago. And some of the key drivers are listed in the paper. So we do propose some minor changes for the second half of this year on the back of the existing corporate objectives ahead of a major refresh in 6 months' time. So they are 3 minor changes: an explicit reference in the collaboration domain to recognise Epsom St Helier as a key partner for collaboration, a recognition of the importance of transformational change to help with our use of resources, and to strengthen the statement on specifically delivery of the opportunities for group collaboration.
Thank you, James. I thought it was really clear, very well set out report. Thank you so much for that. Any questions or comments from colleague Peter?
Thank you, James. I suppose my question is partly recognising the challenge of planning for the medium term, given current state of flux. But is there a risk of a gap between the aspiration and what can actually be delivered, given the resource constraints that we're talking about? And I don't want us to, as it were, depress our aspiration or actually what needs to be done. But if in reality, though, it's going to be exceedingly difficult to deliver because of those resource constraints, are we not? Is there a danger of what signals? How do staff respond to that? How do you manage that process where there is this potential mismatch?
I think it's very important that we are really clear as we have a fundamental refresh of our corporate objectives with our staff, and that they can resonate with staff across the organisation. I think it's fair to say that it's over a year since we've engaged with staff on the existing corporate objectives. So I don't think there will be a fundamental challenge in perhaps a lack of absolute alignment in terms of their day-to-day experiences. And as an executive team, whilst we are focusing on all of these corporate objectives, a key challenge that drives a lot of our discussions and behaviour relates to establishing the group, which are articulated in these corporate objectives, supporting our financial recovery and supporting flow and our elective recovery. So I don't think they're not aligned, but I don't think they are as precise as we would have chosen them to have been if we did have enough time to do this. But we felt that this is a pragmatic way forward, given that there will be a fundamental refresh in a few months' time.
Thank you, James. Jenny?
Just to, I think James has summarised it. When I read through this, I thought that's entirely appropriate for where we are at the moment, and more work's to be done. So I was very supportive of this.
Thank you, Jenny. Seeing lots of nods, are we happy to, Peter, are you okay? Happy to agree the proposed corporate objectives? I thought a job well done, James, if I may say so to you and the team. Thank you. That takes us on then to item 4.5 and the Horizon Scanning Report, which is you, Stephen.
And I can be quite quick on this. This is a paper for noting and information. I'll take it as read. I think for me the key thing on this for me was sort of stepping back from some of the detail that's in the report. You know, there's a fairly extensive briefing on the implications of the Health and Care Act, but also some of the wider system changes and the knock-on effects of the change in legislation, whether that's in terms of the NHS England operating framework, the enforcement guidance, the transactions guidance. There's a large degree of flux in the system and changes to how the system is operating at sort of ICS level and how trusts interact with that. I think that's probably one of the key themes of this report that stood out for me. I think we've talked previously about the messenger review of leadership in the NHS and just saying that the government's accepted those 7 recommendations and we're awaiting hearing about how it plans to then implement those. And I guess the other bit to highlight from this would be the CQC State of Care report, where in one sense what's in that State of Care report is both very familiar, but it's probably no less stark in terms of its overall messages nationally, whether that's around the overall message of gridlock in the system that it references, but the particular challenges around access to care, inequalities, the scale of the workforce challenges across the country, but also then, as we touched on earlier, the specific concerns highlighted with the CQC around maternity services across the country. So those are the bits of the report I wanted to highlight, deliberately steered away from including in this the East Kent Kirkup report and also the priorities published by the Department of Health and Social Care, our plan for patients by the now previous Secretary of State, as we wait to see what the new Secretary of State's changes may be. So a couple of deliberate exclusions there.
Sorry, I pressed the wrong button in the middle of that. I suddenly realised my thing was still on, so I thought, I'll just switch it off and press the wrong button. Thank you very much indeed, Stephen. Any really clear and helpful report as ever. Any questions or comments from colleagues? No? So another of those really useful reports where we simply note it, which always seems so inadequate really, doesn't it? But that's all we're required to do. Thank you very much indeed, Stephen. So that takes us on to item 4.6, which is the Board Assurance Framework, and we're half an hour ahead, which is great, because I really did think closing at 10 to 2 was probably not a great plan. Well done everybody, and I don't think it's been at the expense of having the right discussions. But Stephen, over to you for the Board Assurance Framework report.
Thanks, and again I think this can be fairly concise in that this is the Q2 report. It's probably worth saying, as has been touched on earlier, the relevant risks have been reviewed by the relevant board committees before coming here. There's one risk that's reserved to the board, which is SR4, the system working one, and we'll come on to that in a second. I guess the sort of, in high level terms, there are no proposed changes to risk scores or assurance ratings at this point in the year. But partly touching on Tim's point in relation to the IT risks, I think while there aren't any changes at that level of what are quite broadly framed risks in relation to the strategy element, I think what a number of board committees are seeing is the granular sort of or more detailed risks that sit at the corporate level, and certainly in addition to the work that we've talked about in terms of the Finance Committee, the Quality Committee and the People Committee have been reviewing the corporate risk register risks. And I think one of the things I'd say alongside the BAF is I think those committees probably have greater sight now of the risks that sit on the corporate risk register within these areas. In relation to SR4 and the system working, as I say, that's reserved to board. I think, as I touched on in the last report, the level of flux in the system and the degree of changes flowing from the 2022 Act probably means that we're not at the stage where I think we can reduce that risk score from a 12. I mean, the 12 is lesser within those areas. That within our control, working with the ICS, the progress that we're making in terms of the group, etc. So I thought I'd leave it there.
Thank you, Stephen. Jacqueline.
I was just reflecting on that risk you just talked about, the risk SR4, because I think inherently there's a bit more risk within the system because of our financial position, and it doesn't feel like the most. I'm just trying to find the right word.
Yeah, no, you are. I was going to provide one and decided it wasn't perhaps the most appropriate.
But we are. But yeah. It might need that, I don't think COVID is the risk, it's got here about emerging risks. I'm not sure that is the risk anymore. I think the risk is that because of our financial position currently in the system, we are facing more of a risk within the system than we did previously. And I just think we need to just think a bit more about that. I don't know whether that makes...
No, it makes perfect sense, and I agree with you. And I think we also need to recognise that the system itself is in a state of uncertainty, perhaps, because we've lost our independent chair. And I think that's also had an effect. And I think if you take the two together, it properly should lead us to say, does 4 times 3 still seem right? So I don't know whether anyone else has got a view on that. So you're nodding, Anne, and
Yeah.
Peter's indicating he'd like to speak. So would you like to go first, and then Peter?
No, I was only going to agree. I was reflecting some of the conversations that Jacqueline and I had earlier. It does feel more risky than it has in recent months, and it feels to me that the likelihood is more in the 4 territory than 3.
Peter?
Thank you. It's just trying to understand a little bit more what's lying behind the concerns that you have around the ICS and ICB. I mean, it'd be interesting to understand more the extent to which it's negatively stopping us from doing things that we'd otherwise want to do, or positively there are opportunities not being secured as we...
If I'm being honest, Peter, I think that's a part 2 discussion.
Is it? Okay, fine.
I think that kind of neither and both would be my reaction, which is not a very helpful comment. But we do need to have this discussion but I do get a sense that there's some sympathy around the table for 4-4.
Well, it's a board decision, so I'm happy to go.
But it's important that you have an opportunity to react to a proposal that, Jacqueline and I didn't plan it, but when I was reading, and that if I'd been thinking I was going to do something about it, I'd have spoken to you, but I was kind of thinking it, and then Jacqueline said what I was thinking, so...
I think that they're always fairly nuanced decisions about, is the likelihood of 3 or 4. I mean, they're judgments, and I think the key thing is, from a board perspective, and the purpose of the board framework is that we hold that in our minds in terms of the level of risk that we face. I think in terms of how the risk currently is worded, it's principally around, we're failing to deliver as part of the ICS the fundamental changes necessary to transform and integrate services for patients. I think in terms of the finance bit, that clearly bleeds into this. I mean, what I would say is that on the BAF, the finance risk itself is there as a 25, and that does have a system dimension in and of itself. But I take the point, and if the board collectively feels we're at a 16 rather than a 12, I'm certainly not going to push back on that.
No. I mean, it's how you have this kind of debate, which is kind of thinking aloud in this kind of meeting, really. But it's interesting to me that Jacqueline and I both kind of arrived at the same kind of place.
I think as well, Chairman, there are some of us around here who play more in the system than not. And when you're playing in the system at the moment, not playing is the wrong word, but when you're participating in the system, it feels like it is more high risk than it was. And I think that is where I'm coming from. And so that I would feel more comfortable putting it. And we probably need to do a bit more work with you, Stephen, about why and what that looks like to put in here. But I think that it's worth having a bit more of a discussion in part 2 about that.
So I think that's the way of handling it, Jacqueline. That we note in the minute that we feel that perhaps we need to look more carefully at this. That does mean having a wider discussion, which the formal board doesn't, part 1 doesn't allow for. But we will do that. Think about whether we've got the wording right in a change context. And then I think, Stephen, that might enable us for the next time we bring this report back to give some other options to the board. Does that seem reasonable? Yeah? Is everyone else happy with that? Yes? Okay, so we'll just need quite a careful minute, Patsy, that sums that up. But I think it would be premature for us to move straight to 16 without looking at the wording of SR4 and testing some of our thinking collectively, because as Jacqueline says, some of us spend quite a lot of time in the system and others of us don't. So for now we will leave it, so looking at the recommendation, we will leave it at 12 and good, but we will take that away and look at it with a view to coming back at next time this report is due. And I think for the remaining 9 risks we can endorse what the committees have agreed. Yeah? Everyone happy with that? That's great, thank you very much indeed. So that takes us to the closing administration, and item 5.1 is any questions from governors? We've had no questions from public. Hilary?
Just a comment. What a pleasure it is to have these new microphones, and what a pleasure it's me doing here. So.
Thank you, Hilary. Yeah, certainly some of us said that at the, John and I had that discussion at the beginning. It really does feel delightful to be back, even if there were a few wrinkles at the beginning with some of our visits, but I don't think it was so noticeable and we still got a lot out of it. So thank you very much indeed for that. Adil.
Thank you. I've got a few things just to quickly go through. One is about the C difference, which I picked up.
Adil, I'm so sorry, but given that I have a hearing problem, would you mind using... Yes, thank you, so that I can hear you.
Is that better? Okay. One was just about the C diff rates and the concerns about the slippage on the number of C diff cases compared to benchmarked across other trusts, and what action is being taken to try and address that.
Do you want... shall I get Arlene to answer?
Yeah, please.
So I suppose it's clarifying that it's a trajectory that is set, and it is set mostly based on what the trust did the previous year. So, and in previous years, George's has managed to come under the trajectory set. So, so last year, George's had a trajectory of 44 cases, and it was reduced to 43 because we managed to keep below that 44. It is kind of arbitrary. It's not a national benchmark or anything. Individual trusts have set individual targets based on what they managed to achieve the previous year. In terms of having said that, we are now on 42, and we should have a maximum of 43. So the teams are working, infection control teams are working with the clinical teams on the ground to look at why that is. Currently, every single case we do a root cause analysis for. We look at what happened, timeline. Is there any lapse of care that we were able to identify? So did we do or not do something that we should have done? And we haven't found any. In 2 cases, there was a query about whether we should have stopped antibiotics before we did, and we're looking into those in more detail. But generally speaking, the feeling is that the patients that have had antibiotics have had it appropriately. They needed it, but we do know that antibiotics place patients at higher risk of developing C. diff. So the cases are looked at individually. I suppose as a short answer, we haven't found any, obvious cases where we think that we have horribly got it wrong, and we will continue to do that. But there's very little else that we can do apart from that. And having said that as well, we do know that the rising numbers of C. diff is across London, is the picture across London as well.
Thank you, Arlene. You had another question, Adam?
Yeah, it was just, I was pleased to hear the discussion about the BAF risk register and the kind of consideration that should a risk rating be increased in light of the sort of system concerns at the moment. Does that also reflect the sort of concerns about the slippage in certain diagnostics, like for cancer and for other sort of markers, key performance indicators, or is that reflected elsewhere in the risk register?
Sorry, I didn't fully catch that. Did you, Stephen?
Yeah, I think so,
Would you mind answering it then?
So, I mean, there are, on the corporate risk register, there are specific entries around things like the ED, waiting times, patient flow, that sort of thing. In terms of the board assurance framework, that's captured under the strategic risk 3, which combines both operational performance risks and the IT risks. So that is captured there as part of it. Yeah.
Okay, thanks.
Yeah, two questions, if I may. First of all, the Discharging Care Fund that was recently announced by the government. I gather there's problems. Is that because St George's is sitting on the money, or because the money hasn't been allocated from Whitehall?
As I understand it, the money hasn't reached us yet, John.
Yeah.
And Kate's, am I right? Yeah.
Okay. Second question, can someone give me an update on the renal build, the new build?
Who's best to deal with the renal build? Andrew. Oh, Andrew.
We've informally been given approval to move to the full business case stage and to draft that. But we're waiting for formal approval of that in terms of going forward. So we're starting the preliminary work in terms of doing that case. That means, you know, we can take the case that's been developed and go to the market to identify contractors to support us with the bid, with the build, and actually get firm prices to then take that case back through NHSI and get that approved to then be able to move forward and progress and break ground. So that's where we are at the moment. So it's moving forward and we're in a positive place, we would say, but we're just waiting for some of those final approvals.
So when do we actually think we'll see building start?
It's still 2 to 3 years away at minimum. But we would need to, as you say, we will need to tender for the work. You know, it is a significant value contract, then put the business case through, and then there's all the build that goes with it. So, but as I say, we feel we are in a positive place. So this is, I would term, normal process. Those are normal timelines for a project of that scale when you're at this point. So I wouldn't say there is a delay or any immediate cause concern for that, from that.
And I wonder if I can just add, equally importantly, the renal build is more than just building a new building. It's about integrating two different clinical and managerial and organisational teams, and work is underway to help integrate those teams and to look for early opportunities for effective collaboration of the two renal teams ahead of the building being erected, and that's underway.
Thank you, James, and Andrew, really helpful. I hope that answered the question, John. So thank you to Governors for your questions and contributions. So the next item is about any new risks or issues identified. So I think we had a good discussion about the system risk. Was there anything else that anybody wanted to flag up at this stage? I haven't. There's nothing particularly registered with me, but just in case, no. Any other business? My most disliked category.
That's why we never put any on, Julian.
Well, especially if nobody's ever warned me about it. Anyway, happily, we're all on our best behaviour, so that's great. If we could note the draft agenda for the next meeting. No problems, anybody with that? If we don't have the FPP down on it, Paul, it will be there. Yes.
So do we want to put Kirkup on it as well?
And Kirkup needs to be there, yes. Yeah. So we'll add both of those. Otherwise, we will move on to item 5.5, which is reflections. And I asked Arlene if she would be prepared to lead the reflections today, and she very happily agreed. Thank you, Arlene.
Thank you, Gillian. So, yes. Ooh. Right. Start again. Thank you. It was empty. Reflections on the meeting. I think, everybody was quite happy to be back in this room, and it's my first time having a board meeting in the room, in this room. So, it's quite different, but nice to be in the same room with everybody else. I felt that the wrinkles aside with how it was arranged to do the ward visits, we acknowledge that, but we were then still able to provide some really helpful feedback on the areas that had been visited, and we identified some issues that various people are going to take away and address, and I think that bit is really important because it does give us that insight into what we don't know until we have done the visit. So that was very, very good. I think even in that section we had an acknowledgement that things have got better, and that felt for me really important to acknowledge, and I was pleased to hear the feedback on the wards as well, in particular the staff that people met. I felt that we had a great degree of openness and transparency about when we discussed. There were some issues that we admitted, look, we're not doing as best as we can here, but we were quite comfortable with doing that. And I think having read the Kirkup report is really important that we are able to do that as a board. And I feel that we did do that several times along the way. We had well-written reports, and that was noted, and I think that's very, again, helpful for us in preparation for the meeting, but helpful for people to have that feedback as well as a marker of what would help us as the board when we come here. I also felt that there were good levels of challenge when required. So, when we talked about performance, some areas we acknowledged that it wasn't deteriorating, but it wasn't improving, and we needed to stay on top of it. So, good challenge from everybody, involvement of everybody, and open debate to get to decisions if we needed to. The corporate objectives, we felt job well done is what I've written down because I think that it was important again that we got there. I feel we're coming out of the meeting with clear understanding of the financial position, with acknowledgement that we need to do more. Next month it might change and we will have to do even more. But even the discussion around, how do we grade that on the BAF, I thought was very helpful and will help my thinking, and I'm sure everybody else's. And the final thing I had was that the reports from the committee chairs were all clear and enabled good discussion. It helped those of us who hadn't been at a particular committee to catch up and to understand what was discussed and agreed. And as always, the meeting was really well chaired, meaning that we're finishing on time and early even, and that is always very helpful. Thank you.
Thank you, Arlene. That's really comprehensive and helpful. Anybody else got any? Tim?
Thank you, Chair, and thank you, Arlene, for I was pretty comprehensive, I think, actually, and I agree with lots of things that you said there, particularly about being back together. I think it's really helpful to do that. Just a reflection on the visits, though, and I think I heard a comment at the beginning that when visits were done at Epsom, they're usually surprise visits, as it were. I have to say the visit that we did was absolutely no problem at all. I mean, people there were very welcoming, what have you, and it was clear that it was a bit opportunistic that we arrived at what for them was actually a good time. I heard in Jenny's reflections that it appeared that you might have arrived at a bad time and they were quite busy. And I just would reflect that some parts of the hospital, perhaps arriving as a surprise visitor is not necessarily a good thing. And I don't think, when I look back over the years that we've been doing this, I don't think I've ever felt that when we arrived for a planned visit, we were in some way seeing something that was not normal for the ward. So, doing the sort of secret shopper kind of visit doesn't feel to me to be particularly helpful to the staff that are there.
Thank you, Tim. I think we've heard good and bad about that. We need to take that away and reflect on it. I think certainly, I don't think we got the visit I was on. I don't think we got the best out of it at all. But clearly others did. So, and there is no doubt that there is value in, and I know Arlene would absolutely believe this in the unexpected visit. It's a good test. Anyway, lots of food for thought. Oh, lots of people want to speak. Right, Peter and then Kate. Peter's taken over the chair.
I just wanted
you
to
go.
pick up on Tim's point. I think it's really important these visits don't feel like an inspection. So that is the risk of doing the drop-in as well. I think it's just, and I can tell from what you did, they're not inspections, are they? They're about board members going in, talking to staff and getting a sense of what's working, what's not working. on behalf of the staff in a way than supporting them with that. But I think that it's just, we need to think about that. That's maybe dropping in and maybe feels a bit more like an inspection. So
Yeah.
I sort of agree with Tim, actually.
We'll take it offline, because there's definitely pros and cons that we need to test. Peter?
A good meeting, but we've been going 3 hours, even if it's a little bit shorter than planned, and that's quite a challenge for us, and maybe for those observing, to maintain their full focus, or they may even be in need of a short break. In quality and finance, I think we've now introduced a midpoint 5-minute break. I just wonder whether that may be appropriate for the board as well.
I'll think about it, Peter. I think it's harder with public meetings. So I think these things are always a question of balance. I think the question is whether we can curtail some of the discussion without losing the essence of the purpose of the board and our responsibilities to properly assure. So worth thinking about. And Peter and I have had a discussion anyway about some of the committees in common, where he and I spent Thursday and Friday in very, very long meetings, and Peter suggested, and I think he was probably right, that he and I had experienced an intensity of it that, at non-executive level at any rate, that nobody else had done. So anyway, there we go. James?
Just like to reflect, I felt my heart rate increasing at the start of the meeting, because we were running 20 minutes late, because we were having a good, rich conversation. But I think I underestimated your ability to bring us back on track. So thank you for doing that, and thank you for helping get my heart rate back.
Well, there's also the question of my own heart rate when it begins to go off piste, you see, James. So there's a lot to weigh up in all of this, isn't there? Anyway, thank you, colleagues, for that. I think it is really useful to have a bit of reflection at the end, because apart from anything else, we have to challenge ourselves. And we had that discussion when we were talking about maternity and Kirkup, didn't we? So now we're going. I'm hoping that yes, we have. Excellent. We're moving on to the patient story, and we're joined by Wendy. And I'm so sorry. Oh, have I got the name right? Is it Shazia? Have I pronounced it properly? Yes. Would you both like to come up and join us? Have we got some chairs? Okay. Thank you, Stephen. I don't like you saying. It's like Stephen's sorting it, Wendy. Come in and just come in. Are you okay there? So sit down, make yourselves comfortable. So the purpose of this is for us to learn and hear about the good and the not so good, and so how we can get that, how we can help you get that better. So thank you so much for coming. I know a little bit about the story, but probably not many other people do. So we're in your hands, and we'll probably ask you some questions afterwards. Is that all right? Okay. When are you going to start?
I will indeed. So I'm joined with Shazia, which is fantastic today. So I've got a story that I've met several times with Jackie, who is the carer and wife of Mike, who was an inpatient for 4.5 months at the very beginning of this year. And this is her story as the carer and wife, because Mike was very, very unwell, and Mike doesn't remember a lot of the events, so Jackie was helping to pick it up. So what I'll do is I will tell Jackie's story, and then Shazia will explain from the ward's perspective and the senior health wards how we are learning from that and what we're taking forward to see improvements going forward for other patients. So the one thing just to flag beforehand is that this was not a complaint, this was really just a patient story, this was feedback. So Jackie told her story, and Shazia and her colleagues remember this couple very well, because they were very balanced, they were very down to earth, they didn't flap in any way, and Jackie told her story very naturally, and wasn't sure what I was looking for, so just shared it, and this is really her words and her observations, which is very rich in terms of, and it covered several areas. So without further ado, so Jackie's husband Mike was in hospital for 4.5 months. Mike was very aware that Jackie was sharing it with me, and they've reviewed this several times. So Mike is a very complex patient. He had a complex history. He had 2 lung cancers, Parkinson's, COPD, atrial fibrillation, and severe dysphagia. He also has a hearing impairment. The family are caring for Mike at home now with the assistance of paid carers, and some private carers also have been trained to administer medications via the PEG feeding tube. So Jackie gave her overview as the wife and co-carer of Mike about her experience. Overall, the care was very good, and Jackie was particularly mindful that the Trust was still coping with COVID at this time, impacting on staffing levels, visiting and capacity. Mike was admitted following a rectal bleed at home. He was admitted in January, quickly after the bleed, and assessed through A&E. He's also a Jehovah's Witness. Mike spent 2.5 weeks in the ICU due to very low haemoglobin. He's got no memory of this. He was a patient on Hebden, which is a senior health ward during his stay. There were several standout elements to Jackie's story, either about exceptional care or areas potentially offering some learning. So in the A&E department, he was quickly assessed and his requirements factoring in his blood products because of his Jehovah's Witness. And A&E were very, very good in ensuring that holistic care taking into account his personal needs, which is fabulous to hear. The investigations didn't identify a cause for the bleed, but it was suspected to be diverticulitis. Jackie stated that the cooperation in A&E was phenomenal around his needs, and both Jackie and her son Alex were allowed to be present when visitors were at that time still restricted due to the pandemic. The care received, in Jackie's words, was considered, holistic and well coordinated. So moving on to as he moved through the hospital during his stay. So while he was a patient on Hebden ward, because of his Parkinson's, he received medication every 4 hours. He was listed for a procedure which was a PEG insertion, but he waited quite a number of hours because the procedure was delayed, and he missed 2 doses of his Parkinson's medication. By the time the procedure was complete, he was incredibly stiff, and it took him a very, very long time to recover. The family were actually made aware at the time that he might not recover due to how complex he was and his number of conditions. So during his very long stay, so quite a few months on our senior health wards, things he raised was he found it hard to sleep because it was very noisy. Obviously, if you think about Hebden ward, we've got some cognitive impaired patients and patients with dementia and so forth, and not all of them, so there's a balance. He said it was very noisy. Jackie appreciated that in an older person's ward, this might be a challenge, but she advised that Mike, he wasn't allowed out of his bed or chair without a staff member, and sometimes because of how busy it was, waited quite a while. So Mike and Jackie both talked about the lack of stimulation during this period. And Alex, Mike's son, would call for daily prayers, which was really welcome, and staff supported the family with the technology around the FaceTime. But as a result of a lack of stimulation, his mood was low on discharge. Jackie didn't think that he received sufficient therapy during that period, but Mike pushed himself because he wanted to go home. So moving to the last part of Mike's stay, around the discharge. Despite the fact the family were warned that Mike might not recover more than once during his long stay, he pulled through and was discharged just over 4 months later. Jackie explained that he was discharged with a PEG feeding tube, that they were given a 16-page discharge report, which was overwhelming for the family to follow how the different medications and nutrition and hydration needs should be administered through the PEG. But a consultant and nurse from the hospital at home team went through it all with them in detail the following day about what medications could be combined, food and hydration requirements, which made all the difference. As Mike needs a different combination of medications 7 times a day, this was overwhelming, and the medications were sporadically referenced in the book and very difficult to unpick. Mike was initially discharged with kite support, which stopped after 4 weeks. The kite staff could not touch the PEG, and their assistance was mainly around washing and exercises. The family have arranged private carers to support them, and the family is sharing the load. I'm very happy to report that Mike's mood has improved, and the family are working together.
Thank you, Wendy, so much. That's very clear and clearly raises a whole lot of issues, good and areas for reflection and learning. So, Shazia, we're looking forward to hearing your account from the perspective of the ward.
So in terms of the ward, so there's obviously 4 different areas that we've picked up on that how we can improve in the future and things we've actually already started. So one of them was stimulations for patients. So before COVID, we've got obviously Heberton wards refurbished, and we've got an amazing day room. And we used to have, prior to this, we used to have activities. It used to be led by therapies, and we would have them twice a week. And they were for our cognitively impaired patients, patients with dementia, and anybody actually could participate in them. But they were in place before. Since COVID, everything has, we had to scrap it all. But we have now started again. With the help of Wendy, we're going to try to get volunteers. To start with, we're going to get volunteers in place and just see how this is going to work. We already have the activities and things on the ward. Everything is still here with us. It's just a matter of getting the support to be able to get this going. With obviously the challenges of staff, we can't straight away start with our own staff. I don't think we've got the numbers to be able to accommodate that on a daily basis. So with volunteers, we should be able to go ahead with this. So that was one of the first things that it's all in place. Obviously there was an issue with noise on the ward as well. So we have got things already available through procurement in terms of welcome packs, which have things that could support patients with noise, and I think it's got the eye masks in there. They've got earplugs, headsets as well. So things that we could use, patients could use. So we are trying to get staff, making staff more aware that we can get these things ordered and have them available ready on the ward. So that's one of the other things. Then we've got, in terms of the communication, so obviously 16 pages, a lot of information to take away with you. And considering that when they went home and the following day, they had the hospital home team actually going in and being able to reduce that, then we are trying to get our therapists and so that would be more around the dietitian coming on to the wards and actually just going through the family with them on the ward, so we could reduce the number of papers that would actually be taken away with them. That can be information to them for later, but not things that they need to actually read themselves and try to make sense of what's been happening. And I do actually remember working with Jackie on the ward actually, and because we did spend about a week just trying to teach the family how to use the PEG and what they can do. So they were fairly confident actually before they took Mike home. But obviously a lot of that information with the discharge and medications and stuff, that would probably be available to you the day before. So maybe just putting things into place that it's not available to you the day before, it's actually available to you from your training on the ward. And we do have to train families if they are going to take a patient home with a PEG. So the families, if it's going to be family who's going to be administering the medication, so probably starting that early on so we could potentially reduce what they take home with them. But continuing with the support of having somebody coming to you the day after and actually going through it again. So that's another thing. So that would definitely help with the communication part of it all. And the last thing was the medications, and obviously Parkinson medications, being critical medications that were missed. And we do acknowledge that they were actually missed on 2 separate occasions while the patient was waiting. And it was really unfortunate actually, because he could, when we couldn't get the PEG working and he needed to wait, what we tend to do in situations like that is we tend to have a patch prescribed, a Parkinson's patch prescribed for the patient. And prior to this incident, he did have where he was ill by mouth, and we couldn't get the NG, because before the PEG he had an NG tube, and it blocked, and so we had to get patches prescribed at that point. But the moment that was resolved, you go back to the tablets. So the patches then get discontinued on the medication chart. So they were still available on the ward in his bedside locker, but they just weren't prescribed again. So when he missed the first dose, so he was coming too close to missing his first dose, we could have been a little bit more proactive in making the doctors, speaking to the doctors and getting them to prescribe them again. It's quite easily done. I think it was just maybe, it actually is just trying to making all the staff aware that this is the route that you've got to take, rather than waiting that eventually the PEG is going to get resolved and we're going to give the next dose. Once the first dose was coming to the end, coming to the point of missing that dose, we should have been a little bit more proactive. So it's just teaching staff. I mean, they are aware of what's critical and what's not critical, but just what actions to take in a situation like that. So there is training already in place. We do have Parkinson's nurses regularly visiting and just going through things with the staff, but just making them aware of if it's out of hours, how do we get hold of people just to make sure that doesn't get missed. Jackie was she was lovely and she did understand. She was quite empathetic, but obviously it did result in Mike being quite stiff, and we did notice when he came back it was quite bad. And it took us a lot longer for us to be able to then get him up and sitting out in the chair again, a good couple of days before we went back to normal, and that was very distressing for her sons and for Jackie as well, and for Mike. So there is a lot of learning. Most of it's already started, but yeah, a long way to go.
Well, thank you so much. In the same way, Shazia, you've explained it really clearly and set out in a very open way, I think, how you've embraced the learning and working with your team. So thank you so much for that. And you've been really clear, so there may not be many questions, but just in case there are, Kate and Jacqueline and Richard. So, do you mind? No. Kate.
Hi, thank you both very much. I'm Kate Sennett, Managing Director for St George's, and thank you both for your honesty and also all the work you're doing, Shazia, on the ward. Mine was more of an observation than a question, and I think hospital at night is noisy, isn't it? And I think I was on a ward the other day and speaking to a patient actually, and there was somebody opposite her who was very, very noisy at night. They had been in a side room, but had to come out of the side room because there was somebody with COVID that needed to go into the side room. So side rooms are in short supply at George's and probably in most hospitals. And obviously our management of infection impacts on that as well. But it's more of an observation. It is quite hard, I think, to keep the noise down when you've got somebody who's very calling out at night. And we know that people anyway and patients get quite distressed potentially, particularly when they have dementia at night. So I think it is really, really challenging, without a doubt. But that's interesting about the earplugs and stuff, which I didn't know about. So thank you.
And I've come across that. I was doing a ward visit, and a patient said to me that the great treatment, but noisy at night. And the member of staff who was with me said we can do things about that. So I was really interested in that because my limited experience of hospitals as a patient is they are very noisy places. Jacqueline.
I was just reflecting about nurses, being I wouldn't say I'm a nurse now because it's a long time since anyone let me touch a patient. Yeah, but just thinking about how do we as nurses really understand the impact of drugs and the impact of timeliness? Because there are some drugs that actually you can miss the dose and it doesn't matter, but there's clearly drugs like the one that Mike's on that actually missing 1 or 2 doses has an extreme effect on them. So I'm just wondering whether our and it might be as much for Arlene, who's our chief nurse, as it is to ask you about, do we really educate our nurses enough about pharmacology rather than being the delivery route?
Yes.
If that makes sense, and I don't know what you both think.
It makes perfect sense. So Shazia, if you'd like to react to that, and then I'll go to Arnie.
I think we try to make sure that everybody has enough knowledge, and I think since we've gone online, there is a little bit more support available. It's quite easy, it's a click of a button almost away from just checking up on which medications are critical and what's not. But I think it's probably not enough. There's not enough support out there just trying to, make it, because you've got to remember with wards, especially with our wards, with the staffings and stuff, it's not just your regular staff, it's also the agencies that we use, the bank staff that we use. And obviously you can't control which set of patients are going to get regular staff each shift. And if you've only just got agencies on, then it's about making sure that everybody that's on the ward that is trained. And I think it's just, we probably need to get a little bit more control over what information then we have readily available for new staff that are going to come onto the ward, that we can actually, as a nurse in charge, you can just maybe explain or, make them aware that these things have to be given, or what do we do if this is not being given. But I think since we've been online, there are...
What's being online mean?
Oh, iClip. Since we've
right,
gone
okay.
onto iClip. sorry. Most medications now have this red triangle thing that comes up, and it actually alerts you that this is probably a critical drug. So if you didn't know, you can actually, so some things are there, but again, that requires for the doctors to put that in the notes, and then for the pharmacist also to pick up on it and then make that into a red flag to say this is critical, you cannot miss, or what actions to take if this is missed.
Okay, that's really helpful. Thank you. Arlene, did you want to offer a broader perspective?
Yeah, no, I think so. There is quite a lot of pharmacology in nurse training, but there's also some little things that we can do. And I know because wards are busy places, and I know we had an incident in Epsom St Helier a couple of years ago, exactly like this, where the patient missed their Parkinson's medication, become quite stiff, and fell over. And that team did one simple little thing. They bought these tiny little monitors, timers that they can set. So the nurse that was looking after patients with Parkinson's has it in their pocket, and it just goes off in their pocket when the drug is due. And it's just little things like that and it improved the care for that man in particular. But I must check whether they're still using it. But because everybody gets busy, we just need to find little ways of ensuring that we keep on top of stuff like this. So it might be something that you can do as a QI project, for instance, for your Parkinson's patients.
I think that's a really good way of dealing with it. I think the only difference, the issue we had was we couldn't actually administer it because the route wasn't available. So his peg was actually not ready to be used. So I think we just missed what we didn't do was we should have actually got the tablets switched over to the patches in that at that point. And I think that's what it was. It wasn't until the second dose was also missed that it was picked up on that we should have actually got that switched over to a patch. We did, and he did have the patches after that until the peg was ready to be used. So, but it's actually in terms of for the rest of the patients to have something there just to remind you. And Parkinson's tablets are not your regular 8, 12 and stuff. It's 11 and 1 o'clock and then 3 o'clock, and it's all hours. So, thank you.
Thank you very much indeed. Richard, I think this will probably be the last...
Wheeling's got a hand.
Oh, I'm sorry, then Wheeling, and then that'll be it.
Yeah, well, thank you for the way that you told a really complicated story. I thought it was very clear. It made me think that for people who have multiple long-term conditions, actually planning their discharge, an awful lot needs to be done, doesn't it?
Yes.
It's not like, well done, you're better, go home and have a nice life. And I'm wondering whether you get enough notice of intended discharges to make the process of preparing patients and families as smooth as possible. Because when things don't work well, sometimes the doctors will decide on a ward round, right, we're sending this person home today. The nurses will look a bit startled. Everybody will rush to get all the different multidisciplinary team members together to prepare things. And I'm wondering, do we do that well, or could we be better? What's your thoughts on that?
Well, with the strains on the trust at the moment, it's not really much of a choice. You could on the morning ward round, and it has happened on many occasions that they would, patients ready to go, as long as the package of care, as long as the safety aspects in terms of getting them home safely and everything else is in place, you do have to, allow that to take place. It would be ideal to have a little bit more time to be able to train the families. We do have our pharmacists that ring the families and discuss medications. Then we have our discharge coordinator who will also go through the list with the patients, and if the patient's not able to, is cognitively impaired, they will speak to the family, the next of kin, to go through things. I agree there isn't enough time for those things. With Mike's case, the family actually, it was a 2.5, 3 weeks work progress. We had to give them time because they had to have training on the ward. They actually had to, Alex, the son, as well as Jackie, had to have separate timings to come in to train with the PEG. And they had to independently come in the morning for breakfast, do the medications and start the feed, and then go home, and then come back at lunchtime, somebody else would come. And so that was about 2.5 weeks process. It was a shame in between. He became a little bit unwell. We had to stop, and the nurses had to take over and then start the training again. So eventually, in the last week before he went home, they had to have all that information given to them in writing and say, off you go, which is a problem. That was a lot of information for them to take home, but yeah, we could do more around training families, or speaking to them, or patients as well, in hospital before we send them home. I hope that's possible.
I think the family have done a great job taking Mike home and coping, because lots of families wouldn't be able to, would they?
And they were very adamant that they wanted him home, because we did offer nursing homes to them,
yeah.
And everything was in place, but they were very adamant.
Yeah, no, it's a hugely lovely story, actually, that you managed to help them get him home. Pui Ling, last one from you.
Just a final thought is this, I suspect this will be rare as hen's teeth. My question is around how do we respond to an expert patient? So a patient and family who does know how to manage those drugs that are, a real threat to patient safety, and they bring it in and they insist that this is to be given because you guys are slow, in inverted commas, in giving it to him. To what extent, A, you come across that situation, and B, how would you respond in terms of actually the family knows what they're doing, but the staff is so stretched that you couldn't just take over what they normally do?
You'd be surprised, that happens often. That does happen a lot often. With senior health, you always have families that are so involved and they know everything that's done, and we have families that ring us to remind us that is this done because that was supposed to happen at 8 o'clock and it's 10 o'clock and he's called me to say this hasn't happened. So it does happen often. Where in terms of they come in and they want to take over, that patient is under our care. You cannot come and take over while they're with us. We have to be the providers for that care. We do take on board all the information and everything they give, and we try to provide them support as much as we can. But we are quite. It also depends on what it is that they want to come and take over. If it's medication, then what is prescribed is what has to be given. So that's quite tricky. We've got a good team, and everybody is able to actually speak to the families and explain to them that we are going to do the best that we can. You can't stop the complaints. They may not be happy with what you've just explained to them, and it may go down to PALS and they wanted other things done, and that's fine. We can't stop that, but we do try to minimise complaints, and we do try to allow families to feel involved, but what is critical needs to be in our control. If we're going to be able to deal with and make sure the patient is safe and stuff, that stays with us.
Wendy, final word.
Just on that subject, because it's a very, very large subject, it's huge, and there's lots and lots of talk going on around this nationally in terms of the role of the carer and families caring for patients, and there is a huge increase in families being very, very involved in care. So there's been some updated discharge guidance around looking at how we work with families more holistically, how we allow partners, carers, families, wives, husbands, grown-up children to do that. And so I'm on a group with NHS England, and we are looking at and waiting for a toolkit to come out which gives some very clear expectations. And so once that's received, that will be widely shared, and we can think about how we improve that, do it better, and work with families and carers in kind of a more organic way, if you see where I'm going with that.
Final word, actually, from the Chief Executive.
So I think the thing for me is we've become a very maternal or paternal organisation in the NHS, and actually, if you're there with a child, the parents do most of the care. And so if you're there with somebody who is an older patient, I would think that their family would still want to do most of the care. And I think it's a bit about how do we not become over-obsessed with the legalities of it and actually think about what does the patient want and the family. Because I think we can sometimes take over thinking we're doing it in the best interest of the patient, when actually the best interest of the patient is let the family get on with it. And there are some things, checks and balances, I know we need to put in. But I think that for me is a bit about how do we change our head away from, if we were here 40 years ago, most of these older people wouldn't be in hospital. They'd actually be at home being looked after by their families. And we've become a very different society. So I'd be thrilled if we got back to more family care, because I think it's the right thing for all the family as well as the person who's being cared for. So I look forward to seeing something that doesn't make it even harder for families.
Me too.
So that's a suitably philosophical note on which to finish, I think. I want to say a big thank you again to Shazia and to Wendy, and I'd like you to pass on our thanks to Jackie and Mike, if you don't mind, and say that we're really grateful to them for working with you on this, and it's enabled us to have a really good discussion at board, and as you illustrated, Shazia, so clearly, a lot of learning on the ward as well. So thank you very much indeed. And for the rest of us, it's time for lunch. Thank you. Thank you. Thank you, colleagues.
So much.
And we resume at 2:00.